Good morning, everyone. Welcome to our DESSH Rare Disease Symposium. I am so happy to see everybody here. I'm sorry we're getting off to a few minute late start. Hopefully our Zoom link is working now and everybody is watching us virtually. And for all of you here today, I'm so happy to see you. I wish I made it to the welcome dinner last night. I have so many people to catch up with and say hello to, but for those of you who I did, it was great to see you again. And we're going to get kicked off because we're running a little bit behind schedule, and we've got a very, very tight schedule today. It's amazing after 4 years of doing this how people are coming out of the woodwork to speak to us today and help our community really grow. So I'm thrilled with that. But it's been, we're very lucky to have so many people that want to come and speak with us. I just prepared a few notes, and I wanted to tell you how it is really moving to see our largest gathering here yet. Families, caregivers, clinicians, and friends. You've traveled from across the country and the world to be here. I know how much planning, sacrifice, and energy it takes to make this trip with loved ones who have complex needs like DESSH. Your presence here shows your dedication and your belief in what we're building together. Before we get started, I did want to extend our gratitude to Washington University and St. Louis Children's Hospital for opening their doors to us once again, to the DESSH Foundation Board, our medical advisors, and our generous donors for fueling this mission forward. We also want to recognize the dedicated teams working behind the scenes, from the clinic staff to our planning committee. Your efforts make today possible. Most importantly, I want to highlight our speakers. Each of them has taken time to prepare and share their expertise with us today, and their voices are at the heart of what makes this symposium so meaningful. As a small gesture of gratitude, we have a token gift for each speaker, which we would like to hand out to them as they finish. If we could just have a big round of applause for everyone so far who has been here to put this all together. Thank you. Before we dive in, I just want to go over a few quick housekeeping items so everyone knows what to expect today. You'll find the full agenda in your program. We've divided the day into two parts. First is care and symptom management, and then pathways to treatment. After each presentation, our speakers will, I'm losing my space, everyone. So basically, after every presentation, we have asked them to leave time for questions. For anyone in person, raise your hand. If you're virtual, Melissa Sidebottom is manning our chat, so she'll definitely take questions from the chat. We're going to be able to post all the presentations online, and there's going to be a recording and a transcript of the conference also. And then we are going to have Zoom titles today in German. After today, if for anyone non-German or non-English speakers, you'll be able to have a transcript. This is for the Zoom folks online to download, and we can have translated in your language. Two more items. In 301, we have a hospitality room. So we have all the kids upstairs in room 308 with amazing caregivers today. And if they need you, they will, I'm sure, come and find you. If you need to be with your child, feel free to go speak to them. Kids are welcome to stay in here, of course. But if anyone needs a break, you're welcome to go to room 301. There's going to be a live stream of the conference in there. If you want to be with your child and they want to run around a little bit, you can watch it up there too. So without further ado, I really want to bring in Dr. Shinawi now, if I could, for our very first speaker of the day. Thank you.
So I have a fancy slide. This is the introduction slide for my talk. I'm going to focus on an overview about focusing on the clinical manifestations of DESSH syndrome. I'm going to present our data on a large cohort of patients, more than 100 patients. I would be very happy really to listen to any questions if you have. So in 2015, we described a group of 6 patients with a constellation of findings, including delayed milestones, intellectual disability, behavioral abnormalities, hypotonia, which is decreased muscle tone, and seizures. In addition, those patients exhibited GI abnormalities as well as some eye findings. And we noticed at the time they have remarkable sharing features. To us at the time, we thought that we're talking about a genetic syndrome. And indeed, over the past few years, about 10 years since then, there are many patients who have been described with the same condition, with the same pattern. And this is the time that we start talking about a genetic syndrome, which basically means that these are recurring features, can be clinical, can be physical features, but if you have the same pattern again and again in the patients who have the same condition, this is the time we started talking about genetic syndrome. And this is the actual data that we collected in 101 patients. As you can see, it's a universal finding, the facial differences, what we call dysmorphic features. And honestly, most of these are really good for the clinical geneticist. They don't have any clinical impact. But for the geneticist or other physician, they can be a tool to recognize that this patient has features consistent with DESSH syndrome. It is very commonly seen to the motor delay as well as the speech delay, which is found in about 99-98% of the patients. Behavioral abnormalities are found in the great majority of patients, and we found this to be in about 86%, followed by hypotonia, gastrointestinal problems, which are found in about 3/4 of patients. We did see that also vision abnormalities are common, and the sleep difficulties in about 60% of patients, and seizures, which we did not recognize initially as a common finding. This is also a prominent feature of this condition found in about 1/3 of patients. I'm asked all the time how common DESSH syndrome. And the short answer, we don't know, but we have some data that we collected over the past 10 years. So we are aware of about 50 individuals who were described with this condition in the medical literature. And as I showed you, we collected data on more than 100 patients. But my estimation, based on my communication through emails, through phone calls, virtual meetings with families around the world, my estimation, there are at least somewhere between 200 to 250 individuals with this condition. I'm very convinced that over the years, this number will increase with the increased using of the whole genome sequencing, whole exome sequencing, and panel sequencing. Many countries will start doing this, and most of our data is really limited to the United States, Europe. There are a few patients from South America. I don't have patients actually from Africa, and you can imagine that from Asia, I have a just limited number of patients. I don't have any reason to believe that this condition is limited to certain ethnic groups. I think it's a universal condition. So what do we know about the cohort that we collected? 101 patients, 44 females and 57 males. 90 of these patients have the point mutations, and 11 have the deletion. And we'll talk in a little bit more details the differences between these groups. The current age is, the median of the current age is 12.3 years. And the method of diagnosis were by exome sequencing in 81 patients, chromosomal microarray analysis in 7 patients, panels usually targeted for intellectual disability and autism in 6 patients, and whole genome sequencing was done in 4 patients, and targeted sequencing, which means that a sibling affected and the second sibling is born with similar features. This actually was done in 3 patients. The age at diagnosis is 6 years. The median age of diagnosis is 6 years. And our aim over the years, the next few years, really to try to lower this age of diagnosis. Although we don't know the natural history of this condition, but we know there is a kind of pattern based on different ages. We know that the initial manifestations are very non-specific. It's very difficult really to pinpoint a feature that would tell me as a clinician that this patient had DESSH syndrome, but these findings would include non-specific feeding abnormalities, feeding difficulties, constipation, acid reflux, hypotonia, and some eye abnormalities. Many of those patients actually are seen by ophthalmology, by the eye doctor, before seeing genetics or neurology. We did notice also increased incidence of recurrent infections. Usually these are not really severe infections. This can go from upper respiratory infections, stuffy nose. This can be associated with or without immune deficiency. When they get older, the most prominent features are related really to the delayed milestones, learning disability, intellectual disability. We did notice that almost all patients exhibit gross motor delay. The age of walking, average age of walking, is about 22 months instead of the range that we're familiar with between 10 to 16 months. But fortunately, many of the patients will catch up over time, and they will able to walk, they will able to achieve most of their developmental milestones. Many patients also exhibit fine motor difficulties, and the language acquisition is also delayed. And in average, they start saying the first words around 24 months of age, and sentences sometime between 3 to 4 years. Potty training also can be a challenge because of different reasons. We believe it's really related to the maturity of the brain, and usually the average age is somewhere between 3 to 8 years. I have data to share with you regarding the cognitive disabilities from our large cohort. Unfortunately, only 42 patients underwent formal assessment of their cognitive abilities by measuring the IQ testing. So the good news, most patients exhibit only mild intellectual disability, and those patients definitely have great potential to improve over time with interventions, with therapies, and all of these things, the support they need at school. And here I divided this into different categories. There are few patients who have normal testing, IQ testing. Their IQ really within normal range. This is 3%. The other extreme, this is the 3%. Fortunately, this is really a minority of patients with severe intellectual disability. As you can see, most patients have mild intellectual disability, and moderate about 15 to 16%. We have this category that we assigned as intellectual disability, delayed milestones, none otherwise specified. And our vision for this group, that it would require more characterization, it is somewhere between the mild to the moderate intellectual disability, and also this is about a third of the patients. Dr. Glazer gonna discuss with you more about the behavioral abnormalities, but I would mention here a few of these things. Many families, retrospectively, if you ask them, did you notice something unusual during infancy? Many would tell you fuzziness was one of those features. My child, they describe their infants as colicky. Again, this is a common finding, right? But I'm not saying that this is really indicative for DESSH syndrome, but this is from the data we collected. Later in life, ADHD, autism become more prominent. Other features, some aggressive behaviors, including self-injurious behaviors, OCD, impulsivity, stubbornness. Many families are familiar with these terms. And the sleep abnormalities are found in about 60% of patients. Falling asleep, difficulty during maintaining the sleep. Night terror was mentioned to me by many families. And the sleep apnea, this is another feature that we also noticed. Many families are describing high tolerance to pain and temperature. And this is a common finding that is found actually in many patients with autism, regardless of the underlying diagnoses. And this is the breakdown of the data we collected. The most common one, you can imagine, ADHD, formally diagnosed ADHD or ADHD features. Autism is about 2/3 of the patients. Aggression and self-injurious behavior. Anxiety, I didn't recognize this feature as a prominent feature in our initial research in this field. OCD and impulsivity that I already mentioned. When they get older, we have some indication that there can be some other mental challenges. Anxiety become more prominent, depression, and psychosis. There are a few cases of psychosis that would require medication. Again, these are statistics. It doesn't translate to the individual patient. It doesn't mean that your child would have all of these features. These are good, really, from the statistical standpoint, from the research standpoint. But for the individual patient, it's different, right? So your child either have autism or do not have autism. It doesn't mean that 2/3 chance of having autism. So this is yes or no. Neurological finding, Dr. Weisenberg gonna discuss these in more details. But I can tell you at this point that 3/4 of patients exhibit hypotonia. I already mentioned 1/3 exhibit some kind of seizure. There are different types, and they can be limited to the night. And the age of onset somewhere between 2 months to 15 years based on our data. There is some indication that maybe there is a correlation between the presence of seizure and the severity of the condition. But we need to confirm this in more statistical way. Abnormal EEG was documented in our cohort in 18% of the patients. Brain imaging was done in a good number of patients. At least 70% underwent brain MRI, and 45% of those individuals who underwent brain MRI, had some abnormalities, but these are not really well defined. So this would include ventriculomegaly as a recurring feature, abnormal corpus callosum, And there is some indication maybe there are also other white matter abnormalities. There is indication also that patients with epilepsy are more likely to have abnormal brain MRI findings. You're gonna see Dr. Reynolds tomorrow and Friday in the clinic, and she's our expert in ophthalmology, and she's familiar with this condition. So about 3/4 of patients have some eye abnormalities. The most common one, these are the refractive errors, myopia, nearsightedness, farsightedness, which are easy to handle either with glasses. Strabismus is common, is found in about 60% of patients. You would ask many families, yes, my child already underwent surgical procedure for the strabismus to correct the alignment of the eyes. And there are other features as well. Lazy eye is also common. Increasingly, we recognize the cortical visual impairment as one of the features of this condition, and Dr. Reynolds is trying to characterize this in a better way. 3/4 of patients exhibit GI symptoms. Dr. American gonna discuss this in more details, but I would tell you at this point that the most common, this is the constipation. Many patients actually receive medications for constipation early in life, during the first 2 years of life. Feeding difficulties, acid reflux are also common, but fortunately this would resolve over time. Many, but not all individuals have what we call recognizable gestalt, which means for the clinical geneticist, when you see a child, you would say that this child has this syndrome or this genetic condition. For me, I saw so many patients with this condition. I do see recognizable facial features for most patients, not all patients. And we are trying to create a scale of these features. I'm going to show you some of the findings that we collected so far. But the most characteristic, these are the broad forehead. The eyes are very characteristic. They are deep set and long eyes. Their mouth, when they smile, especially when they smile, it's a wide mouth. They have very beautiful smile, by the way. Hirsutism, this is hair on their body. This is another feature of this condition. And many of you recognize those gentlemen and ladies, and this is amazing. So although, they are not related to each other, but you can see the similarities. Sometimes you would say, are they sibling or something like that? Some of the features that we didn't realize initially are prominent features. These are the feet abnormalities. Somehow, based on my data, it looks like these are more common among females. Why? I don't know. But you can see to the right the big toe anomaly. We call this the hallux valgus deformity. Nail abnormalities are really we recognize these as common findings. Dental anomalies, the teeth anomalies, either the shape, either discoloration of the teeth. And the next slide, this is the presence of excessive hair and fusion between the eyebrows. We call this in our terminology synophrys or uni eyebrow. And sometimes there can be creases and pits. As I told you, these are not really clinically significant features, but for the geneticist, for the clinician, they can be a feature to recognize when we evaluate the patient, to suspect this diagnosis. Although you would argue we have availability now of exome sequencing, whole genome sequencing, why we need to make this effort and do the detailed this morphology exam. So I'm an old-fashioned person. I still teach my trainees to do the correct physical exam, the correct dysmorphology exam, because I believe these are really important things to recognize and to document in the charts. So here we collected really huge amount of data. To the left, you can see that the eyes are really the most prominent, the face, and the mouth. These are the three prominent features. But if I see also hirsutism, the skeletal findings are emerging findings that we should recognize over time. So what is the etiology? What is the cause of DESSH syndrome? It is caused by mutations in a gene that we call the WAC. So what is the source of WAC? So this is the WW domain containing adapter coiled coil. This is the last time I'm going to say it this way. So WAC, much easier. So this is the name of the gene. We have weird names in genetics. And so a single mutation, we have 2 copies for each gene in our body. And if one with the mutation, this can cause the condition, despite the fact that other copy is working perfectly in a normal range. So the great majority of patients have point mutations, changes in the gene itself. But as I mentioned before, there can be a missing piece on the short arm of a chromosome 10 where the WAC gene is located. So this can include a missing the whole gene with adjacent genes to the WAC. It depends how big is the missing piece there. And in fact, when we initially described our cohort, we mentioned that 10p deletion, patients with 10p deletion, they exhibit most of the clinical findings that we see among patients with the point mutation, indicating that the WAC is the most important gene in that interval. One distinguishing features, and this is also correct based on our own data, this is the presence of congenital heart defects. Almost every patient with the deletion have congenital heart defects, and this is our recommendation. If you have a deletion, you need really to order an echocardiography to look for these findings. So our conclusion was that when we observed that the lack of one copy of the WAC, there is a terminology that we use in genetics, haploinsufficiency. This is the main cause of the facial features, the clinical findings in patients with the 10p deletion. And this is a major question. Many times I'm asked by many families, should we call this condition DESSH syndrome with the deletion? In my opinion, yes, but for the very large deletions, the story can be different. Those patients can exhibit more intellectual disability, more delayed milestones, in addition to the congenital heart defects. Is there any genotype-phenotype correlation? You ask yourself why there are so many differences between patients. If you evaluate intellectual disability, why we have variations? So we have, based on our data from our large cohort of patients, there can be some indication that the type of the mutation is important. The location of the mutation in the gene can be also another factor, but also there can be other non-yet identified genetic modifiers that would affect the WAC gene. So we tend to think about these monogenic conditions in isolation, but in reality, it's important really to recognize the fact that we have a network of interaction between different genes that may affect actually the function of each protein in our body. This protein do not work in isolation. They interact with many other proteins, and this kind of interaction can be different between patients. We have also some indication that demographics may affect also the presentation. There are the gender differences can be a factor there. To the right, you can see some differences between females and males. Unfortunately, I didn't include the statistics, and we are working on it at this point. But despite the fact that the mental and the behavioral abnormalities, at least based on our cohort, are slightly higher among females, we do see that among males, they have higher chance of having autistic features, higher chance of having aggression and self-injurious behavior. To the left, you can see the location of the mutations. So if the mutation within the first half of the protein, it looks like there are, they have less prevalence of overweight, and they have higher rate of having mild delayed milestones, mild intellectual disability, which means that they are less affected because the other group, they would have higher rate of moderate to more severe intellectual disability. We evaluated the type of the mutations. So the most common mutation among our cohort, among patients in our cohort, this is what we call the frame shift mutation, found in about 50% of the patients. And we found some differences. For instance, patients with the frame mutation, they have a higher rate of hypotonia and GI abnormalities, and lower rate of behavioral mental problems and abnormal echocardiography. Why? You would ask why. We don't have any clue at this point, but it's good to have this observation. This can be a clue for us to think about studies in the future. So most cases of DESSH syndrome are caused by mutations, a brand new mutation. These are the de novo mutations. And in fact, most affected individuals in our cohort have a de novo mutation, which means if you test mom and dad, they are negative for the same mutation. So these are considered as random events, and they're not affected by anything of during pregnancy, chemicals or diet and things like that. These are mostly typo errors that would occur, although we have some indication that there can be some pattern there, and we're going to mention this in our article. So there are 4 to 5 familial cases, which means parents were negative, they were canceled, your chance of having another child almost 0. But then they would have a second child with the DESSH syndrome, despite the fact they are negative. So this is considered as germline mosaicism in one of the parents. They are negative in their blood, but the mutation can be found either in the sperms or in the eggs, which usually we don't routinely test. And therefore, usually we say that Erin, our genetic counselor, Erin, will discuss with you in a little bit more details this issue. Recent data indicated that there are familial cases. I have actually few families which are illustrated here. So the most common pattern is to the right. You can see it there. That you have a single child in the family affected, mom and dad are not affected. But we have 3 families in our cohort, one of the parents is affected, okay? And there are more than one child with the mutation. And in the lower panel, you can see here that parents, you test them in blood. To the right here, you can see that the parents are completely negative. But the other 2 families, when they tested the blood, they found what we call mosaicism, which means low rate of the mutation. They're not affected. They're doing just fine. But when they did the exome or the whole genome sequencing, they found very small rate of the mutation in their blood. This is what we call somatic mosaicism, and this is the reason we usually counsel those families of a slightly increased risk of having another child with this condition. So how the name was created to call this DESSH syndrome. So in the world of genetics, OMIM, which is the online inheritance in man, does the nomenclature of the conditions. And this is the OMIM. This is kind of a comprehensive collection of human genes, phenotypes, different genetic conditions. So they assigned this name for this condition. You would argue why not to call it WAC syndrome. So, in fact, if you search the literature, if you search different websites, you would see another name of this condition, WAC-related disorder, which is completely fine, but there can be some potential limitation. One of them that one gene can cause a number of genetic conditions. Sometimes this can be less convenient for families. I mean, WAC with the connotation and things like that can be weird, actually, to call this wacky syndrome. And gene names sometimes would change over time. So we should be, but officially, this is the name of the condition in OMIM. I would leave it just because of short time, and I need to cover a few other things that are important in the next few slides. I would leave the function of the WAC to our basic scientists. So what is next? How we can go, what exactly our vision for this effort? So the way I see it, we need to study. I know that 100 patients is really a large number, but again, for statistical analysis, you need even larger. Big data is really the clue for doing good quality of research. So we want really to expand this a little bit more so we can recognize the full spectrum of manifestations, study individuals longitudinally. This is what we call natural history, to see whether there is a pattern. We know, for instance, hypotonia would improve over time. We know, for instance, that most patients, although struggle in the first 2 years of life with their motor skills, but ultimately will be able to walk, to run. So it's good really to have this kind of pattern. Study animal model. This is the third mission, really, to basic science, to study the animal models and the function of the WAC protein, and to study the effect of therapies. So medicine was created not just to make a diagnosis. Actually, we make a diagnosis to offer treatment, right? This is the meaning of medicine. And until recently, we were focusing on making a diagnosis, counseling families, but this is not medicine. Medicine is really to provide medicine, right? And to provide some treatment, some medication. This can be gene therapy, this can be other intervention, and you will hear exciting news about different efforts here. So large data, why I'm emphasizing this large data. So large data is so important in this field. So for instance, randomly, I was asking about medication taken by patients. And I didn't realize this before. 2/3 of patients actually taking medications. And when we analyzed which kind of medication they're taking, so it does make sense. They're taking laxatives, right, to treat their constipation. They're taking a seizure medication. They're taking acid-reducing medication, which does make sense. But we're surprised, actually, to see that 1/3 of patients almost taking allergy medication, asthma medication, which wasn't really a feature that we recognized before. So this is a window for us really to study these in a little bit more details. Look at the stimulants, for instance, for ADHD. And so this is really very exciting. Another illustration why big data is important. When we collected the BMI, this is the ratio between the weight and the height of patients. We recognize that there is what we call skewing. So to this, you can see the normal standard curve in the middle there. This is the normal distribution in ideal situation without any environmental modifiers for the BMI for being overweight. But you can recognize very quickly, just visually, that those patients having really skewing to the right of the BMI. In fact, more than 26% of individuals have BMI greater than the 90th percentile. The same with the height, but this time skewing to the left. They are shorter, right? You can see the clustering to the left there. They are shorter. In fact, 22% of individuals have height below 10%. And a feature that I didn't really, when we measure the head size, we noticed that they have larger head, which is really a very important feature. In the field of autism, for instance, there is a correlation between having a larger head and autistic features. So this is kind of statistic, and this is the most exciting slide. So I was working over the past few months to build what we call a severity score. Severity score is very important in natural history studies, in clinical trials, and things like that. How we built this, so this is based on my observation that patients, so I chose different elements from the data I collected and thought these can be important actually as a feature of the illustrating the severity of this condition. So these would include number of therapies the patient is receiving. Physical therapy, I would give them a score of 1. Physical occupational would give them a score of 2. Speech, OT, PT, score of 3. Above 3 therapies, this is score of 4. Seizure, the presence or absence of seizure, the number of the behavioral abnormalities. I have a scoring also for the dysmorphic features, the presence or absence of hypotonia, abnormal EEG, abnormal MRI findings, age of walking, age of the first word, any sleep, vision, GI abnormalities, and lastly, the degree of the intellectual disability. I applied this score on our cohort, and this is the results that we got. So 1% of the patients have a score between 0 to 10. The majority of patients have a score between 21 to, so the total score, I forgot to mention, the total score here is 50, between 0 to 50. Having 50, this is the most severe that you can get, and the lower the score, the better the severity of the condition. So these are the 44% with the score between 21 to 30, and 31 to 40, 27, and 41 to 55%. So why it's important? It's important because this will illustrate the changes from year to year. We can apply the same severity score every year. And if we do any clinical trial, we can starting point whether we see changes over time. So this is more objective way, and this is required by usually the FDA for any approval of future medication. Lastly, I'm going to talk about the research opportunities that we're having here. So we have wonderful basic scientists that they're going to discuss the second half of this symposium. They're going to illustrate the utility of animal models, in vitro studies. But one important thing that, needless to say this, but it's so important to thank the DESSH Foundation for their effort in collaboration with WashU to maintain this clinic. I see this really as a major effort. This is the 4th year we're doing this. We collected a huge amount of data, and we will continue to do that. Why it's important to maintain the clinic? So this is a multidisciplinary setting which will help us to evaluate and manage complex needs for many families. Number two, we get experts in this field. To see the average geneticist or neurologist or a clinician to be expert in any condition, you need to see at least 20 patients. You cannot consider yourself as an expert if you see one patient with that condition. So this is a second advantage, and this is a way to do natural history study. Natural history study to longitudinally follow many patients, to see the changes over time, to monitor for any abnormal features or change in their motor skills and things like that. And the collection of biological samples, it's so important really for the basic science research. And this clinic highlights the collaboration, the wonderful collaboration between the academia and the family support group. This is not a one-person effort. I wish I have time really to thank every single one listed here, but this is really a huge effort, mostly volunteering from basic scientists to clinician, to dietitian, to genetic counselors, to administrative people here at WashU. So everyone I listed. Most of you interacted with Kimberly. She is the main person of contact for us. She communicated with most of you. Kathy Cisco is here. I can see she is here, our dietitians there. And this is the first year that we're getting our dietitians involved for any questions. Our pediatric neurology. Dr. Weisenberg and the other neurologist here. Ophthalmology, Dr. Reynolds. This is the fourth year she's with us. She's very familiar with this condition. The IDDRC and the psychology services, they're amazing. They're doing a formal assessment, quantitative data. We'll collect quantitative data. And more recently, we got the biostatistics department involved in the analysis of our data. The PCRU, this is the location of the where we're going to have the clinic, a wonderful team. You're going to see them, the nurses there. They are so lovely. And last acknowledgement, this is for the DESSH Foundation. So this is really, again, amazing effort to maintain this clinic for the fourth year. And that's it. Thank you.
Thank you so much, Dr. Shinawi. I so appreciate it. We couldn't do this without him. This is all here because of this man and this institution and bringing us all together. So please, another round of applause. Oh yeah, go ahead. You can give that to him. Here you go.
Thank you so much.
Thank you. I'd like to bring up Dr. Judith Weisenberg for our next presentation. He's just Dr. Weisenberg has been seeing folks, many of you in clinics, from the very beginning here. So we're really excited. This is the first year we're able to hear from her directly at our symposium. I'm excited to hear the words she has to share with us today and her experiences with all of us as patients.
Good morning, and thank you everyone for having me. Thank you especially to Dr. Shinawi for getting me involved 4 years ago. It's really a privilege to be here at the symposium, and it has been an even greater privilege to be in the clinic for the past 4 years. I'm a pediatric neurologist with additional training in epilepsy, but in my day-to-day clinic, actually a lot of my clinic is also a variety of rare genetic conditions, and Dr. Shinawi and I have collaborated for many years before, especially before we had such readily available good genetic testing. Also, one of the other things I do is co-direct our Rett clinic, which Rett syndrome was described in the 1960s, and the gene was identified in 1999, and that has served as a great model for the potential of what can be done, but now we can hopefully do it much faster because technology has caught up. So My goal today is to give a very quick and hopefully practical overview of the neurologic manifestations of DESSH syndrome. And I want to be very clear that I found it interesting. Dr. Shinawi said that, you know, if you've seen 20 patients, that makes you an expert now, apparently. Okay. But, you know, Dr. Schlager, who was a neurologist here now at Kennedy Krieger, once told me you can call yourself an expert if you become an expert if you call yourself one. I would add, but any real expert knows that they don't know everything. So I titled this talk, One Neurologist's Perspective. It is the perspective of a neurologist who's been in this clinic for 4 years. And I've learned a lot, but we have a lot more to learn. But my goal is to hopefully give you some very practical tools to take away back to your home clinics. So you keep on hearing certain terms. And so the neurologic manifestations of DESSH syndrome that we know of include hypotonia, learning difficulties or intellectual disability, speech delay and gross motor delay, abnormalities in the EEG to seizures, we'll be talking more about that, MRI findings. So I want to get into a little bit more about these specific terms. So hypotonia comes up a lot, but in the end, I think the key take-home point about hypotonia is it doesn't actually end up usually causing significant functional impact, but it's usually a clue that we need to look for something. So tone is something that most people who aren't neurologists never think about. It's that balance between how tight and how relaxed we keep our muscles. And when we assess it as a neurologist, we're feeling for that response to passive range of motion. You may notice a neurologist just moving your child's limbs through a range of motion, and we're feeling for, is it stiff, is it loose? And sometimes it's hard to even define it. You just get comfortable with what it should feel like at different ages and in different limbs. Now, to be clear, in the full spectrum of neurology, it can be a clue that you have a problem with the brain, the spinal cord, the nerve, or the muscle, and reflexes will help us also with that exam. But in DESSH, it really is typically something that we think is related to the brain, but not a serious problem, really just a clue. So, MRI findings. So again, this is really more, from the practical standpoint, one of the ways that when something is being noticed, a symptom is being noticed, developmental delay or abnormal tone, we get an MRI, a picture of the brain, because we're trying to figure out what could be going on. Do we have an explanation? And from looking at our cohort over these years, we have found a couple of patterns, and one of them is, at this point we have 47 total data points, that the ventricles may be enlarged. And the ventricles are these fluid-filled spaces in the center of the brain. Your brain essentially has a plumbing system. It floats in a body of fluid called the spinal fluid to help sort of serve as a cushion. There are conditions out there, something called hydrocephalus, where there's a blockage in that drainage system that causes pressure in the brain, and that will also give you big ventricles. But here, we think the problem has more to do with some differences in how the tissue right next to the ventricles was developed. I suspect that there may be some correlation between the size of the ventricles or how early it's noticed and outcome, but do not hold me to that because we have a lot more to learn. The corpus callosum, I have pointed out here with these arrows, is a bundle of nerves that talks between the two sides of the brain. And there have been some reports of some differences in the shape or appearance of it on MRI. This is what we call very nonspecific. There are a lot of developmental conditions. If you look at large case series of autism, where there will be reports of differences in the shape or size of the corpus callosum. And I think, again, this reflects really a difference in earlier brain development that is also resulting in the symptoms. But there is not something about this. So for instance, this is not something that you need a neurosurgeon to do anything about. You don't need a shunt. It's very important to understand these are really more clues of what might be going on as opposed to something that requires treatment. So this slide I really put in, I think in the interest of time I'll spare it, but it kind of highlights what some key principles in what we know about early brain development and the ventricles, and I think that ultimately, as we start to understand the genetics and the role of this WAC gene, we may get some clues, hopefully for targeted treatment. So moving into some more practical things of what we actually see in our children, we start noticing that developmental milestones are not necessarily happening according to what the baby books say. And so you start getting to hear all these lovely terms like global developmental delay or intellectual disability. Global developmental delay is a very nonspecific term. It just means that in multiple areas of development, and the key areas that we break down are fine motor, your ability to do small, precise things with your hands, buttons, snaps, early on, that pincer grasp we talk about, picking up a Cheerio to feed yourself, gross motor, learning to roll, walk, run, language, which is both receptive and expressive, and social. And if a child has delays in multiple of those milestones, you get this broad, nonspecific term of global developmental delay. Intellectual disability is technically made as a diagnosis by both having an IQ number, keeping in mind that timing may affect, and performance on any one day may affect that number, and impact on day-to-day function. One term that I think we need to explore a little bit more in development is apraxia. Some of you may have heard this from therapists. Apraxia is a neurologic condition in which motor planning or language planning is impacted. So we don't even think about it, right? But everything we do requires a series of steps. To form a word, you have to have the coordination of your mouth, your lips, and also the signal from the brain of which sound, which word you want to come out. And in my unofficial observations, I think that is a lot of what impacts the language and motor development, because we do not have weakness from what we have seen on exams. So there are many different reasons a child might have delay in their motor coordination, severe tone abnormalities, weakness, but apraxia is another way that this may come out. And the good news about that, as we are seeing with our children, is that they are responsive to time and practice and therapy, that they will make progress. And I think possibly the most important point I have on my slides is that we expect development to go forward. And if it is plateauing or going backwards, that is actually a red flag that we need to stop and think, are we missing something? I'm not going to get too much more into some of the other terms, but as you know, autism, ADHD, and many other terms get thrown out. And these are all clinical diagnoses made based on an array of symptoms. Dr. Glazer will be talking more about that. But they are useful because they can give us clues on what may be the best treatment, both from therapy and medication. And so ultimately, when it comes to the management of developmental disorders, just the real practicalities, there are a lot of medications out there. Some of them are targeted to ADHD, some of them are targeted to behavior. But the most important thing about it is really to take an interdisciplinary approach where you're working with a good team of therapists, and ideally have a good team in your school or your educational support team. And don't forget general health. If vision isn't optimized, if nutrition isn't optimized, if sleep isn't optimized, none of us do well. So, the land I live in a lot of the time, seizures and epilepsy. I think this is probably one of the things that does create the most distress. And it's not surprising to anybody who's ever witnessed even one seizure. It is not pleasant to see. At the same time, they are actually quite common. We have many children in our general neurology clinic who will have a couple of seizures in childhood and go on to do just fine. The key thing is knowing what to worry about and how to handle it. So just a couple of vocabulary words here. Seizure refers to an individual event caused by unhealthy electrical activity in the brain. Epilepsy refers to a condition, a medical diagnosis in which you are prone to having recurrent unprovoked seizures. What do I mean by unprovoked? Well, any of us are capable of having a seizure if our blood sugar is low enough, if our brain gets deprived of enough oxygen. But what we know is that epilepsy, where you are going on to have that high risk of recurrent seizures, you would either make that diagnosis when we've seen 2 or more unprovoked seizures, or 1 seizure plus a high risk for more. And those risk factors can include a variety of things, including an EEG. So an EEG is that test where they put wires on your child's head and tell them to hold still and hopefully go to sleep. That goes variably well. But in the end, it is a recording at whatever period of time it is obtained of the electrical activity of the brain. And there are a variety of abnormalities that we're looking for. Do the right and the left side look about the same? Are the brain speeds what we would expect for that age? Are there markers of risk for seizures? So typically brain waves are smooth, but sharp waves, and when they literally look pointy on an EEG, indicate that too many nerves are firing at once. And I like to use the analogy of a spark, and a seizure would be a fire. So if we see sparks, then there's an increased risk for seizures. But that does not necessarily mean your child has epilepsy or will have a seizure. It just increases their risk and therefore your anxiety. So the important thing to know is that seizures are treatable, but not every person who has had a seizure or an abnormal EEG necessarily needs medication to prevent them, because we want to be strategic. The medications are not a guarantee your child will never have another seizure, but in the right setting, they can improve their safety. That being said, they can have side effects. So what is the role of an EEG? If you have had events concerning for seizures, or you've definitely had a seizure and we're trying to work up more what type of seizures they might be, then an EEG is useful. But it does not tell you, oh, you will have your next seizure next week or next year. And it does not tell you if you have had a seizure in the past. It just tells us whether it's more or less likely. So the diagnosis of seizure and epilepsy is very much a clinical one. It requires careful history taking and a good dialogue with a neurologist. When should an EEG be performed? If there are new abnormal spells that have not been seen before, if you're considering changing seizure medications or weaning off of them, if a frequent spell is occurring that we're really not sure, we can do EEG videos. We do them for up to a week sometimes in the hospital, or we do ambulatory EEGs here for up to 3 days at home. You have to tolerate wearing the equipment. And then in my bigger world, when we're considering brain surgery to treat epilepsy, we do a lot of EEG work. So taking it back to DESSH syndrome, what we know so far is that not everyone has epilepsy, even if they have an abnormal EEG. The best data we have is what Dr. Shinawi shared, maybe about a third. But I look at that with a grain of salt, because what I do know is that we are seeing abnormalities on EEG, and I'll talk about that more. And I do know that there may be some behavioral differences or tendency for what we call stereotyped spells or behaviors. And so if a neurologist is just seeing your child without much information and they hear a description of an event and they see an abnormal EEG, their impulse may be to put them on a seizure medication, an anti-seizure medication, just to be safe. And that's not wrong, because we want to be safe, but it needs a little bit of thought. The good news is, from what we've seen so far, most individuals who do have epilepsy with DESSH syndrome, and I emphasize that's most, seem to respond well to medication. And what we call refractory or drug-resistant epilepsy seems to be rare. And what we've also seen so far is that it usually is presenting in the childhood years. And we consider the childhood years those sort of after toddler but before adolescence. And so I wish I could tell you, if you've made it to those teenage years or older, that you don't have to worry at all, but I'm hopeful that that will be the case. And we do not have good statistics yet. We need that long-term natural history study data to answer that better. So we have some data so far, and what we are seeing most commonly is focal sharp waves. What that means is there's an array of about 20 electrodes on the head, and we'll see sharp waves in just one or two of them, maybe one or two of them on both sides of the brain. The key thing to know is if you step back into the world of pediatric epilepsy, this is a common finding in many childhood epilepsies. I also see it in some other developmental syndromes. So early in Rett syndrome, where epilepsy is over 70%, that will be their first EEG pattern. However, it gets much worse for them. We haven't seen that yet in DESSH. Again, we have less data. But there are other neurodevelopmental conditions and even some what we used to call benign and now call self-limited epilepsies of childhood, where we see that similar appearance on the EEG in the childhood years. So it's specific in terms of risk for epilepsy. We know it gives you a higher risk of epilepsy, but it's not specific to DESSH. I also want to mention one other topic. There is a term that you may have seen out there if you're really looking called ESES, or electrical status epilepticus in slow wave sleep, say that 20 times fast, which others' name is DEE-SWAS, because yes, we have an international league against epilepsy, and they just revised all the terminology a few years ago. But in case you're wondering, that stands for developmental and epileptic encephalopathy with spike and slow wave in, in active sleep, yes. So this is a complicated and poorly understood condition in pediatric epilepsy. But what we know is that this pattern I mentioned, if you look on the right, hopefully, and I don't know if this has, does this have a laser on it? The one that looks quieter, less sharp, you can see some little pointy things, hopefully, on that top and bottom image. Does it have it? Yeah. Okay, sorry. I'm not very good at technology. Oh, it's this thing? Okay, thanks. So this is one child's EEG with what we call the self-limited epilepsy with centrotemporal sharps in wake and sleep. And hopefully you see these pointy things. That's when they're awake, and then when they're asleep, they get busier. A child with ESES, or what we now call DEE-SWAS, when they're awake, the EEG looks perfect, but when they go to sleep, that is not a good-looking EEG. But I don't just want to know the EEG. The other thing that we see in these clear-cut cases is a dramatic developmental regression. They may also be having clinical seizures. And in those cases, there are targeted and specific medication approaches that we take that can improve developmental outcome and are important because we're seeing actual loss of milestones. So there's been at least one report of this in the DESSH literature, but it wasn't at our institution, and I have not personally met that patient. And the cynical, carefully analytic side of me wants to know, was it an overread of the EEG, or did this, what I have said, this person met clinical criterion? But for now, I advise all of you, if you're seeing regression in your child's development, or if their seizures seem to be out of control, we need to pay attention. Simple, right? So, a word about anti-seizure medications. This is an old slide. It's from 2011. And guess what? There are even more medications. So this is just to tell you how many seizure medications there are out there now. We have over 30 of them, and this slide is way behind because I can rattle off a bunch more that have emerged since then. But my point is, if you're being told you have this choice or that choice and that's it, that's not true. There's more. Now, none of them are perfect. So how do we decide what medication to use? So, types of seizures, and I'm not going to get too much into that, but roughly there are focal and generalized seizures, and some medications are only good for focal seizures, whereas others can work for all seizure types. Epilepsy syndrome, and you can get a more specific name for epilepsy if your child has epilepsy in some settings. So this is beyond the genetic diagnosis, but the picture of types of seizures. We also want to consider the potential side effects, which can include anything from making your child sleepy, which is the most common, to increased risk of kidney stones, et cetera. some behavioral side effects, but some of them also help improve mood. So sometimes there are secondary benefits to the medication you might pick. Obviously, cost has to be a consideration, the efficacy, the odds that it will work. But the most important thing is to thoughtfully consider your options, try it, and then if it's not working either because of side effects or seizure control, thoughtfully consider transitioning to another medication. Unfortunately, there is no one test that can tell you exactly which medication is going to work at exactly what dose. So, in looking at the world of DESSH and what we know so far about epilepsy, I think we're typically dealing with focal seizures and focal epilepsy. And so therefore, some medications that are specifically targeted to focal seizures, such as oxcarbazepine or trileptal, lamotrigine or lamictal, may be excellent choices. But there have been rare cases where that seems to actually activate the EEG, make those sharp waves more frequent. So if that is a consideration, a follow-up EEG may be beneficial in assuring that you're not getting a negative effect from the treatment, even if seizures are going well. We obviously want to avoid medications that may exacerbate negative behavioral symptoms. Levetiracetam does have that history. That being said, every individual responds differently. Its other name, by the way, is Keppra. But so dose adjustment and so it can be dose dependent, and just carefully assessing and adjusting slowly can really help with that. As I mentioned, on the other hand, some of these medicines, for instance, can be mood stabilizers or actually help behavior, so that can be a good thing. The most important thing is to understand that your child is not one gene. So if you're talking to other people within the DESSH community and they say, this medication is terrible, absolutely don't use it, well, that may well have been true for their child, but that doesn't mean it's going to be true for every child with DESSH. I briefly wanted to touch on clonazepam because I know in the community there's been a lot of discussion about this among some people recently. So I just wanted to make you aware of what we know about clonazepam. It is a long-acting benzodiazepine. A benzodiazepine is a medication that acts on the GABAergic, which is one of the calming chemicals in the brain. Long-acting, it can stay in your system for up to 12 hours. It's an old medicine. In the US, it was FDA approved in 1975, and its initial indication was for epilepsy. We actually prescribe it extremely frequently here, but we usually prescribe it in the short term. It's a good medication to use for a few days while you're adjusting another seizure medication if there are active seizures. It is also used for anxiety and sometimes in the world of psychiatry. So we have a lot of data about its safety. The most common side effects include sedation and excess oral secretions, excuse me, or drooling, all of which are reversible by stopping it. And there have been situations in which I've used it in that DEE SWAS setting to calm down very active discharges on an EEG. So I know there is some discussion of, should my child just be on clonazepam because they have DESSH syndrome? We don't know the answer to that. We also don't know what dose we would use. We know what is a safe range of dosing when we're using it for seizure prevention. We do know that it may impact the findings on an EEG, so I highly recommend that if that medication is being tried, that a baseline EEG that includes sleep be obtained first. And it will take a long time for us to know the full potential benefit, how long you would need to take it, and at what dose. So I'm going to sort of wrap up there. Hopefully, I've given you a little bit of insight into some of the things that, as a neurologist in the world of DESSH syndrome, I've been thinking about. The key things are supporting, monitoring and optimizing development, being very thoughtful about medication management, and getting into good therapies. Really assemble your team, people you trust, and it's the specialist that you pick, whether it's a neurologist or a developmental pediatrician. The most important thing is that you feel like you can have a good dialogue with them, where they acknowledge that they don't know everything, and you acknowledge that you don't know everything, and what are what are the goals and how do we get there. But your community includes the school and your local community, and of course, this wonderful community right here. All right, and I will pause there for questions.
Hi. Oh, I'm over here.
Okay, sorry. I
She's
hear a
doing
voice. Okay, sorry.
She's hiding.
Yeah.
So my daughter had seizures from the age of 6 until 9.
Mm-hmm.
She's now 15. She hasn't had one since she was 9.5 or so. And she's not on medication any longer since age 11 or 12.
Good.
So almost all of them were nighttime only. I think out of all of her seizures, she only had maybe 3 that were during awake cycles. However, all of her EEGs were done during awake cycles. No one ever suggested that we do an overnight or a sleep EEG. So I have no idea what's going on in her waves during sleep.
Yeah. Yeah, and I don't want to ask about personal question in front of the larger group, but what I would say is if consistent developmental progress was made and she's doing well now, that's good, but I would be curious what it looked like at that point.
Okay.
Yeah.
So, but my question was, do you think it would be important, like, I really don't know what we expect of the DESSH teenagers, like, after having gone through seizures or not, or whatever during learning process, like, how much advancement we expect. We just don't know yet.
Correct.
So
Yeah.
I don't know if she's progressing like at a normal rate or if it is inhibited at all. So do you suggest a sleep EEG?
So it's a safe test to get.
Okay.
I think the key thing to be aware of if you go into that is if it shows a few sharp waves at night, I wouldn't necessarily say, oh my gosh, put her
No.
back on a medication.
Sure, no, absolutely.
But if it showed extreme abnormalities, then that might be worth a discussion. But yeah, that's actually a complicated question because we also don't know the full developmental trajectory or how to predict what rate of development is. Your question did actually, though, remind me of one other point, which is I kind of alluded to it, but yes, these discharges do seem to come out more in sleep, which is common for a lot of childhood epilepsies, that we'll see the abnormalities more in sleep. And for individuals who maybe don't feel super comfortable, especially after we stuck a bunch of things on them and stuck them in a room, you may not, in a strange room, you may not get sleep. And so getting a normal awake-only EEG does not tell you as much as a EEG that includes awake and sleep. Also, nighttime monitoring devices do exist for seizures, and I didn't put a slide in about that because there's just so much to talk about, but I can try to share a little bit of information about that. Yeah.
Hey, my name is Tyler. Thank you so much for being here. I'm just wondering, so Dr. Shinawi had mentioned 101 people. You've mentioned for MRIs, for example, you had 47. As someone who, our son had an MRI before we knew of his diagnoses, I'm wondering, are you guys asking, like, we'd be happy to give you any and everything. Are you guys asking for that stuff? And if so, great. If not, please ask. Some of us will be willing to share things you maybe don't already have to increase the number of patients.
Yeah, so Dr. Shinawi and Kimberly could answer the question better, but yeah, we are trying to gather as many records as possible as part of the research. And records can be quite a fun process to collect because we're dealing with lots of different institutions. And the truth is for MRI and EEG data, the actual pictures and the actual tracings, whether we can get them sent digitally or on a disk, is better than the reports. So the more of that we get, the better our understanding will be. And I think records are being asked, but yeah.
My question is just, whenever they did a CT scan or an MRI for my son, it was more to kind of figure out what was causing his feeding issues. But now that I know that he has DESSH, I would like to get like another MRI just to kind of see all those brain waves that you were talking about. How can I go about requesting that to my neurologist or to get it done?
So to be clear, there's two tests. One is an MRI, which is a picture of the brain structure. For that, you have to lay in a scanner that's very noisy for 30 to 40 minutes and hold still. And that might require sedation. So there is some risk to an MRI if you have to do sedation. The other thing I could have talked about is that the brain does develop for every child. It doesn't look the same at birth as it will look at age 2, as it will look when you're older. Generally, we say that by age 2, the majority of myelination, which is the coating, the insulation that goes on your nerve cells, the white matter, the majority of that is present. So if you've had a brain MRI after age 2, we've seen a pretty good example of how the development is going. In terms of the EEG, that's when we stick these wires on your head, and you can be awake for that, but we'd like you to go to sleep, but you should not. We try to avoid sedation, both because sedation comes with a small risk and because it actually can impact what we see on the EEG. For both of those tests, talking to your primary neurologist or your primary physicians, if there is a clinical indication, they can be obtained. Yeah.
Hello, my name is Gabe. I'm the interpreter here with the hospital, and I'm here with Mom. So my question is, how do we access an EEG or an MRI test with this hospital if a doctor in Mexico discharged my daughter, and does it have any follow-ups because as they say, there's no surgery related, and I've noticed that she presents involuntary movements while sleeping.
Okay. So she was discharged, and they said she doesn't need any additional testing. Yeah, that is there an option to go back and, are they aware of the new symptom? Okay, I would start by telling them about the new symptom. Certainly getting testing, at another hospital, including here, is an option, but it can get complicated, unfortunately, on the clinical side with costs and insurance and things like that. So it can be worked out with some planning, but I would start by speaking to your local doctor. Yeah.
Good morning, doctor. Thanks for all the information. We wanted to find out that is there a way to really identify a seizure during the sleep? Why I'm asking that question is I have two daughters, 13 years and 8 years. Both of them have DESSH. Mm-hmm. And not really concerned about the elder one, but the younger one, we've had instances in the past where we've kind of suddenly seen, she's been having a good growth, and suddenly there's kind of a slight regression that happens. And when we consulted neuro there, we talked about an EEG, but she was not cooperating at all for the EEG to happen. How do you really identify a seizure in sleep? What is the way? I mean, we've not been able to understand that yet.
So there are a couple of issues there. One is the tolerance for the EEG. And for some individuals, the biggest issue is getting the electrodes on. And so in those cases, if we think they'll keep the electrodes on once they're on, and our techs here do a really good job with head wraps, then we will, in rare instances, actually sedate with a specific anesthetic that shouldn't affect the EEG as much, just long enough to get the leads on. In terms of figuring out if seizures are being missed in sleep, we can try to address that question somewhat. You can do an overnight EEG. You can do an overnight EEG for up to a week. If you do it for one night and you don't see a seizure, then you're probably not having a seizure every night. If you do it for 2 nights, then you're probably not having a seizure every other night. But ultimately, we don't have a perfect mobile seizure detection system. By the way, researchers are working on small implanted devices that we might be able to use. You may have seen there are some seizure monitoring systems that you can even wear with one of those smart watches with a phone. But a lot of what those are using is called actigraphy, which can measure rhythmicity of movement over time. So if you have a very rhythmic movement for 30 seconds or more, then you may be having tonic-clonic activity, but not all seizures present that way. So there's no perfect way, But a reasonable screen, if you're worried that you're missing frequent seizures, would be to do a couple night EEG overnight, but you do have to be able to get those leads on in the first place. Okay.
Hello, thank you very much. I was just wondering, is there any place for doing EEGs to predict seizures? And then I actually had a second question. And my other question was just if you have a normal MRI under 1, I know you said that the brain sort of continues to develop. Is there any indication, or would you recommend repeating that MRI at some point?
Yeah. So
Thank you.
To the first question, we would tell you that the incidence is higher than the general population. You're a higher risk than the general population if you have sharp waves on an EEG. But we also are seeing that many individuals with DESSH syndrome have that. So right now, I would say it really isn't a good predictor and may just raise your anxiety level to just get an EEG randomly without a clinical concern. In terms of the MRI, if it looks normal at 1, it's probably going to look normal after age 2, because what we're seeing so far, again, preliminarily, is that those abnormalities probably show up from early on. But again, we have limited information. Okay. Thank you, everyone, so much.
Thank you, Dr. Weisenberg. I'd like to introduce/reintroduce Dr. Paul Glazer, who has been a staple at our clinics from the very beginning. A lot of wealth of information from him that you'll learn today. I know one of the cornerstone challenges of our DESSH kiddos are behavioral problems, and so this man is going to really help enlighten us on best practices for managing that with them. Thank you, Dr. Glazer.
Thank you. And the human brain's really only designed to pay attention for 45 minutes. Well, 20 if you guys have ADHD. So feel free to get up during my talk. I know it's not a break, but I will not be offended as long as you don't offend the people around you. So this interesting thing called behavioral management and neurodevelopmental disorders is what we're going to tackle today. And as we know already, the people with DESSH have a lot of psychiatric issues or behavioral issues, whichever one you want to call them. And they've actually done a study, Dr. Shinawi was part of this one, where they've looked at the rates of these things. And as you can see, the highest one there is OCD, or obsessive compulsive disorder. We see a lot of ADHD. Anxiety seems to be a key. Or nervios, if you've heard of that one. And then aggression, of course. About half of them have been diagnosed with autism. And I would say just about every patient or person I've met with DESSH has some autistic traits. So even if you don't have the full diagnosis, you probably do have some of the traits. So what are we going to do with all this? I mean, this is a lot of stuff to struggle with. It does mean that day to day, your children and as teenagers and adults, they will have lots of behavioral issues. So it means that you're going to have a lot of sleepless nights, troubles when you try to get them into the school system. So my goal today is just to give you the range of things that you can use to help address these needs and help your child feel better about life and help you get by without pulling your hair out every day. I would say one of the core problems, though, is people with DESSH tend to have speech troubles. And if you cannot talk, if you cannot tell, human beings are very, language-oriented beings. If you can't tell people what's going on inside you, it can create a host of behaviors. So they might be self-stimming, but really what they're trying to tell you is, my bladder's full, or I've got a headache, and yet they can't use those words, so it comes out as their behaviors. So remember, behaviors are not just always because they have those diagnoses. Sometimes it's just their way of communicating. So in some ways, you have to become a good interpreter. Pick someone in the family who's really good at body language, or teach them, a lot of speech therapists can work with you to get assisted devices to help them speak, and that can really help sometimes. Now, if you do go to a psychiatrist or developmental pediatrician or neurologist, depending on your community, this is what you'll get. The case of the parable of the 7 doctors and an elephant. Everyone will probably call it a different diagnosis, but all the symptoms are the same. And let's face it, our children are a lot more complex than any one diagnosis. So not that the diagnoses aren't helpful, but more helpful is finding either the behavioral intervention or the medicine or both that help them out. So a couple of things about, before you even get to medicine, what are some of the behavioral management strategies you can do? Well, first of all, you can teach yourself how to parent a difficult child, and there are parent trainings there. You can take them to behavioral therapies, such as play therapy. As they get older, if they have more language, they can do cognitive behavioral therapy, so are those listed. Specifically, one good reason, at least in Missouri, to get the diagnosis of autism is it qualifies you for ABA therapy, or applied behavioral analysis. And this is the #1 treatment for kids that are irritable and aggressive, or are doing some things like, say, self-harming, like banging their head so hard you're worried that they are gonna, or picking the same scab over and over and it starts getting infected. ABA is probably one of the best ways. It is very labor intensive. Once again, you probably need the diagnosis of autism to get it covered by insurance, but it's very good, and I've avoided some medicines for kids if they've been able to get this. One of the most common parent trainings is parent-child interaction therapy. A lot of insurances don't cover this yet, but if you can access this either in person or online, this is a good way to help you, establish a way of dealing with troublesome behaviors as they come up. And some ABA therapists can even teach you how to do some of the ABA techniques, which can be useful. Just remember, too, if you do have medical issues along the way, behavioral therapies can help with some of these, especially things like bowel issues, constipation. Oftentimes, those are behaviorally driven. Like I have some patients that only will go potty in one place in the house, and if they go to school, they're not going to use the potty. Well, that leads to a lot of issues. So then you have to come up with strategies to help deal with that potty behavior, and also to deal with the constipation as well. All right, there are other add-ons that can help out with behavioral. Occupational therapy is a really big help if there are sensory issues, sensory being overwhelmed or by sounds or textures, and they can also be really good for the social withdrawal that some of these children have if you do want them to learn social skills as they get older. Some of the speech therapy can help with the assistive communication devices, and then physical therapy with various forms of exercise. Our kids do need exercise, even though it's been taken out of the school curriculum. It's really helpful for those with behavioral issues, especially ADHD. Now, one of the questions from last year was what to do about stimming behavior. So this was a question one of you submitted. I would say you have to look at what is the stimming behavior doing. At least in the autism world, some stimming can be helpful. It's a way that kids deal with their anxiety. It's a way that they show that they're excited. And you don't really want to get rid of that if it's doing something helpful. Obviously, if it's part of a seizure, you want to get to a neurologist and an EEG for that. If it's a very harmful stimming behavior, even if your child likes doing it over and over again, but like the head banging, the self-harm, then you may need behavioral interventions or medications for that. So I think the main enlightenment there is just not all stimming behaviors are bad in the autism world, at least. Now, iPad therapy, this is not an actual therapy, but it does help your kid's behavior for a short time. I would say it's hard to get around. You can't really avoid it. So what's better maybe is at a young age, as soon as you introduce this, at whatever age you introduce screens, just make sure you always put a time limit on it so that they get used to the fact that this is not something they can do nonstop. One of the most, and you want to put, of course, have maybe software on there to limit access to dangerous sites or predators as they get older. But I think the main thing is just having that limit, knowing that this is something that can be helpful, but needs to be done in short term. Otherwise, it's very impossible to get them off of it. And some of the worst aggression I've seen in my patients is a child who's used to being able to use the screen 15 hours a day, and then the parent finally has to decide to get them off of it. And that's very aggressive behavior. It's really like dealing with an addict in a way. All right. What my own recommendations to you, if you do look for behavioral management, is to be eclectic about it, to know that we don't really have one intervention that helps kids with DESSH syndrome. The other way to say that is DESSH is maybe one or a combination of genes, maybe a handful of genes, but there are about 1,000 to 10,000 genes that determine our behavior. So really, their behaviors probably more reflect your own behaviors as a child than the DESSH syndrome. And the fact that they can't communicate makes those worse, brings those out more. So if anything does run in the family, make sure your doctor knows about that as well, because that could also guide what things are actually going to need medicines. Is this mood swings? Well, if you have a high family history of bipolar, it might be good to go on the medicines for mood control at a younger age, just knowing that this could be helpful for them long term. The other thing I recommend is finding books or methods that fit your philosophy. There's lots of different strategies. Here's just one of them, of many that I know parents have used. This one's called Raising Your Spirited Child. You can find that book. The points it makes are make sure you're not alone, that other, like you're doing here today, network with other families that have kids so that when you have a troublesome behavior, they should be your first go-to even before the doctor. Like, what did you do when so-and-so started smearing poop on the wall? What am I gonna do? And just see if they had any practical advice that worked. The second part is not being guilty about it, making sure you know you did not make your child spirited. The third one is know you're not powerless, you can take control. The fourth is to take permission to take care of yourself, have those mental health wellness breaks in your day, in your life. And then finally, celebrate and enjoy all the delights of your child, because they're going to come with a lot of positives too. So sometimes we forget to be thankful for all the joyful aspects of having a child with DESSH. There's many books online, and if you ever do, I'm sure Caitlin and others would be able to contact me if they ever want to have a specific recommendations, or what do I think of a certain book? Because some books are very helpful and parent-driven. Other helps have a second agenda and are very profit and may not be helpful for you. All right. This was a combination of questions we got from last year. What about behavioral troubles as a teen or as an adult? What should I expect? What's the prognosis for what they will become? And will they ever be independent? Who will take care of my child when they're older? Or if something, God forbid, ever happens to me? So I would say we don't really have the data specifically for DESSH, so I'm going to just go off of my patients who have similar either genetic or other behavioral issues and I would say it really depends mostly on their language and their social skills. So work on those as soon as you can when they're younger. The more they have language, the more they can become independent. And then social skills are also helpful when it comes to getting into the job market. I do have some patients that when they go to adulthood, we get them disabilities so they can have vocational rehab, but then they have useful jobs and then they either stay at home or they get into assisted living where they can get assistance with their medications or seeing the doctor and stuff like that. And that has allowed some of my patients to get out of the house and be independent. I have a few on the autism spectrum, of course, that are completely independent, but they do need a combination of doctors and therapists to get by. Anxiety and depression are the biggest things I see in teenagers, because they're getting to the age now where they realize I am different from other kids my age. And I want to have friends, but everyone teases me or bullies me, and they have bad experiences. So I really look out for the anxiety, depression at that age. And then as adults, they usually settle down, they find their people, and they're much calmer. So that's just a little, a broad brush of what to expect in the future. Obviously, if you have no language when you're 18, they may have to stay with you the rest of their lives, or they can get to a facility if they're in state custody. Although I discourage that because no one can receive as good as care as they can from their own family. So I will skip over this in the interest of time, but this is all the genetic studies that maybe some of you even in the audience have done, and you've had some of these speakers here. It just suggests to me that there's a lot of GABA dysfunction and glutamate overactivity, just neurotransmitters in the brain. That leads to the seizure troubles, but it also leads to the behavioral troubles. Anxiety and OCD are really driven by the brain just having cycles of the same thought over and over again. That's why they love doing those, repetitive behaviors. So the same medicines that can be helpful for seizures sometimes can be helpful to slow down those behaviors as well. And I often will be the first one to start anti-seizure medicines in my patients with genetic syndromes because the EEG is not showing much, but we really need it for their behaviors, and I don't need an EEG to start those medicines. If behavioral therapy is not enough, sometimes we do have to use medicines. I think I'm not going to spend a lot of time on these because you really need a good one-on-one relationship with a doctor who knows these medicines well. So I do recommend that you get a psychiatrist or a developmental pediatrician involved at a young age if you have a lot of behavioral issues. But here are some of the ones I've been using, some of these atypical antipsychotics, which actually have some FDA approvals for autism, irritability, and one that's not on there is lurasidone now. Latuda has just been approved as well. Naltrexone, by the way, is sometimes helpful for self-harm, and sometimes we use that because it blocks the pain signal or the reward from the pain signal that people indirectly get. So sometimes that does reduce self-harm. If anxiety is a trouble, we use some of these commonly known anti-anxiety medicines. I would say the strongest one, though, is the clonazepam that Dr. Weisenberg also mentioned, which boosts GABA. So I have a few patients long-term on that. I do tend to avoid it because it can be a little habit-forming over time, and so sometimes it's hard to keep a dose that works. But some of my patients are on that long-term. And then ADHD medicines are sometimes tried. They don't always work as well as straightforward ADHD, but they can be helpful. And then here's the anti-seizure medicines that I've used the most. And, actually, two of them mentioned by Dr. Weisenberg, lamotrigine and oxcarbazepine have been very helpful. But there's other ones. I also tend to avoid the Keppra or the levetiracetam, which tends to make aggression or self-harm worse. And so sometimes we do need a sleep study, but here are some of the medicines I use for sleep. Melatonin is definitely the number one. And then some of the calmer ones or less side effect ones are clonidine and Benadryl. Benadryl is actually over the counter. And then some of the stronger ones for my very difficult kids that don't respond or they get used to those sleep medicines are trazodone, quetiapine, mirtazapine, and benzodiazepines like the clonazepam. So maybe show this list to your doctor if you do have someone who's constantly waking up. And then finally, the best medicines are just trying as much as you can to put structure and sameness in their life. Your kids, most of them will love this, knowing what to predict, and having a set schedule, family focus was really important. So as much as you can emphasize that, that'll be great. I would think, so for questions, I think, unless you have one that's really like a broad one, I think I'll go outside because a lot of psychiatric questions are really personal and one-on-one, and that way we can get to our next speaker as well. So before I finish up, anyone have just a very broad question, not one where you want to tell me about your child? Well, I do love to hear about your child, but... Oh, did I go through that too fast? Yeah, I'm very hyper. All right. And I have executive functioning deficit, by the way, too. So yeah, there's that for those people who want to take that. All right, another general question here in the front.
I was just wondering if thank you. I've been aware of oppositional defiance disorder,
Yeah.
but only recently became aware of, I think it's PDA, demand avoidance.
Persistent
Is
avoidance.
there, can you kind of draw a distinction between the two? I'm just very new to the term PDA.
So at least my perspective as a psychiatrist is it's just calling a different part of the elephant a different name. But they all come from the same source, which is usually either like a combination of impulsiveness coupled with a little obsessiveness about getting what you want. And therefore, that will make you either avoid things you don't like to do that are not your preferred activity, or to act oppositional to an adult who's trying to get you to do what's actually the healthiest or better thing for you to do. So I think it's just renaming. It doesn't change any of the approach we have in terms of medicines or behavioral treatment. So yeah, thanks for that question. All right, there, I see two more general questions.
We have one with selective mutism,
Yeah.
and we're not on any medication or anything, but it makes discipline tough because she totally shuts down.
She shuts down. All right, I approach that first with behavioral issues, and then if our behavioral therapy to try to see what you can do to help her express her emotions, and then I would target, all right, so the next one would be to try the medicines, and also wait for time. But yeah, or have a really good therapist who continues to work with you on other techniques. Otherwise, truthfully, it's one of the hardest things to treat. So if you're having difficulties, we can talk about that more out there. So, all right, last general question.
Hi, thanks very much. Just a general question about sleep tactics. With kids who haven't got DESSH, my older kids, I did control crying. Is there evidence that that's harmful in kids with DESSH to try and get them to sleep?
So where you just kind of leave them to cry themselves to sleep.
You go back, maybe it's a UK thing, maybe I'm looking really horrible, and maybe I'm just going to get hated now. But they're older, so it's a different generation. But you go, let them cry for 10 minutes, go back, let them cry for 10 minutes, and that's what I did with my older three. Is there evidence that can cause harm, or is that not done in the US at all? Am I just showing my difference?
It is still recommended in some circles.
I'm going to forget that question. Nothing, no questions at all. My wife is looking at me very badly at the moment.
Oh. Well, my first comment is you're such a cruel bloke. So, no, my real comment is that I think it is still recommended among some circles. It is an old school way, but it does work for most people. But I would say in general, my patients with DESSH and other syndromes like that are so obsessive that they're not going to stop crying. And if that's, then give it up right away and try something else. So don't stress it, don't push it, don't let other people convince you that it's going to work for your child. Your child's so unique, you have to take it day by day and night by night. All right, thank you for your attention.
Thank you so much, Dr. Glazer. Our next speaker is Dr. Karine Amarikian. She spoke with us last year for the first time. She is a GI specialist, and I know a lot of us struggle with some GI-related issues, and we're so happy to have her on board to speak with us today.
Hello, everyone. It is truly a pleasure and an honor to be here today and to share some information about gastrointestinal manifestations in DESSH syndrome. So just by disclosure, I also do eosinophilic esophagitis, and I was on the medical advisory board for Sanofi, but this has nothing to do with my talk. So as I was preparing for this talk, you guys were asked, what are some of the main questions that you have about GI problems in your kids? And some of the things that came up most frequently were just GI health in general, GI disturbances, dysphagia, difficulty swallowing, feeding issues, a lot of sensory issues, and then the concern about inadequate nutrition, GI dysmotility, constipation, potty training. So we're gonna talk about all of these things. I sort of broke it down into 3 general categories that seem to be prevalent in patients with DESSH syndrome. So constipation, gastroesophageal reflux and dysphagia or swallowing difficulties, and feeding and nutrition. And these are our objectives that I hope to go over today. So first we'll talk about constipation. So what are the causes of constipation? This is a question that commonly comes up. And there are many causes, and I think some of these are, as we heard in the earlier talks today, can be particularly relevant to patients with DESSH syndrome. So, simple things, not enough fluid intake, not enough fiber intake, some medication side effects, behavioral difficulties. Of course, holding the stool in, that's something very common in young kids. And then there are anatomical issues such as a stricture, Hirschsprung's disease, anorectal malformations, hypotonia, as we heard earlier today. When you have low tone, it is just kind of difficult to gather the strength to push the poop out, and as well as metabolic and neurologic implications that can affect constipation. So in DESSH syndrome, I think the most relevant things would be hypotonia and behavior features, and sometimes some medications, including anti-epileptic medications that can have side effects of constipation, as well as the diet. Going over the anatomical issues in constipation, so there could be some congenital problems such as Hirschsprung's disease, but also, when kids have chronic constipation and, they've been dealing with this for a long time, especially if they start holding the poop in from a young age, and then what happens is that the rectum gets dilated. And here, this is a barium enema, so this is basically just a contrast study. So it's an enema where the material that is injected is contrast, and then they take an x-ray. And this is the outline of the rectum and the colon. And so all of this is poop. So you can see how over time, if kids continue to hold the poop in, it really creates this problem where the rectum and colon and everything further upstream can get very dilated. And then in turn, you need kind of a bigger load of stool in order for the child to feel a sensation that they need to have a bowel movement. And by the time that happens, you may have a big sort of rectal plug here, and you may have liquid stool going around. So constipation can be very tricky sometimes. So this is one of the things that we hope to avoid by treating constipation early. And another thing that can happen, for example, if this happens to a child, and then even if all the stool is cleared out, the colon still remains dilated. And the issue with that, it could be that the colon becomes very floppy, and so it can turn and twist, and that's called a volvulus. And you can have a sigmoid volvulus, and that can be a surgical emergency, and you may have to have a resection. So these are, constipation is very important to address, and, it's important to start treating it early so that we can avoid these kind of things from happening. The typical way that we treat constipation is with Miralax. So Miralax is our #1 go-to medication. In our pediatric GI world, we consider this to be the safest and most benign medicine, and also the most effective. It is basically a powder that is mixed with liquid. It can be mixed with water, juice, anything that the child likes. And ideally it should be drank quickly, like within a couple minutes, and that way it works better. In addition, even if your child does consume a lot of fiber, and Miralax is basically a fiber, it is also important to make sure your child drinks lots of water, because without the water, the fiber will not really do its job. And the idea behind Miralax is to make the poop soft so that it comes out more easily. Exercise is also very helpful, and being active, it stimulates the bowels to contract and empty and move things along. Stimulants such as X-Lax or Senna, this is a common over-the-counter medicine. X-Lax, it's basically these like little chocolate squares, so kids often like taking them, and we use them quite often together with Miralax, because X-Lax works on the muscles of the intestine to push the poop out, while Miralax makes the poop soft and more easier to come out. And then, of course, you can also use additional suppositories or enemas, which are very helpful in getting that initial rectal plug out. And once, if you're able to do that, then these two medications work better after that. Alternative treatments, if this has been going on for a long time and things are not, working out, you're still having problems. Other things that we do is anal Botox injections. So this is when Botox is injected into the internal anal sphincter, and this is a procedure under anesthesia. And basically that Botox helps that internal anal sphincter muscle to relax and allow more passage of the stool. This can be really helpful in kids who are withholding the stool. This procedure can be done up to every 3 months, and typically the Botox does wear off at the 3-month mark, so often kids need to do this repeatedly. But sometimes when medications don't work, this can be helpful. And if that doesn't help, we also have it's sort of like a little tube that can be placed through the skin into the cecum right here. So this is the colon, the rectum is here, and then this is the cecum, which is the first part of the colon. And you can place a little tube. It's kind of like I don't know if any of you have heard of a G-tube, but it looks very similar, except it goes into the cecum. It's basically access from the skin, from the outside, directly into the colon. And if you have such a tube, then what you can do is flush with some liquid, and usually this is done once a day. Basically, you flush all the poop out. So you put a lot of liquid in through here that then pushes all this poop out from the beginning of the colon to the end. So that is, of course, a surgical treatment. We try to avoid this, but sometimes it is needed. And, an important point that I just really want to make is that it's very important to treat the constipation right away. Because the longer constipation goes on, the more likely, the behavior, sort of like the child adjusts to this behavior, and this cycle just tends to continue and is more difficult to break, and also requires more time to actively be working on this in order to heal that rectal dilation and make it go back to its normal size. The next topic I'll talk about is gastroesophageal reflux. So this is when acidic contents from the stomach go up backwards into the esophagus, and then that acidic fluid causes mucosal damage to the esophagus, and it can cause pain, and that can lead to some difficulty swallowing. This is a picture, kind of like a visual demonstration of a contrast study. This is an upper GI, so when a child swallows the contrast and then they take an X-ray picture, and that is not the gold standard way of diagnosing reflux, but this just demonstrates the idea of reflux. So this is your esophagus, and you see the contrast backing up all the way up into the thoracic area. And this can intermittently happen, and it just happened to be captured on this image. And then this is the endoscopic view. So when we are concerned about severe reflux and dysphagia in a patient, we can do an endoscopy, an upper endoscopy, where we go in and we look at the esophagus and we take biopsies. And so this is a picture of what the esophagus looks like when there is gastroesophageal reflux disease, meaning that you see this little ulcer. Overall, the mucosa is quite red and irritated. You don't see the blood vessels very well. But you see here these little ulcers indicate that there's been acidic damage to the mucosa. So as I mentioned, endoscopy, how to diagnose gastroesophageal reflux. So the gold standard is this 24-hour pH impedance probe study. And that's when a probe is inserted into the nose, down the esophagus, into the stomach, and it's supposed to be there for 24 hours, and it measures the pH, and it can actually count the number of incidences that reflux has occurred, and you can also see if there was anything like a cough or a particular movement or something that precipitated the reflux episode. But unfortunately, this is quite a difficult study, as you can imagine, to have a probe in your nose for 24 hours. So we don't do this very often, but it is the gold standard way of making this diagnosis. Additional studies that we do that are much more simpler is the endoscopy, but that is under anesthesia, but that is a direct way that you can look at the mucosa, take a biopsy of the mucosa, and see, if there is actually mucosal damage. Now, if everything looks normal on there, that doesn't mean you don't have reflux. It just could mean that the acid has not yet caused any damage to the mucosa, which is good. And then another study, similar to the pH impedance probe study, is called high-resolution esophageal manometry. And this is, again, another probe that goes into the nose, down the esophagus, into the stomach. And this time, this probe measures the pressure in the esophagus and the peristaltic waves, and it can sort of give you a picture of how the esophagus moves and how the muscles are coordinated and whether that is normal or not. Because if that motility aspect of the esophagus is not normal, that could be a reason for why the reflux is occurring. In addition, that study can assess the area of what we call the gastroesophageal junction and the lower esophageal sphincter, which is a sphincter between the esophagus and the stomach. And that sphincter is actually, it opens and closes. And so if that sphincter seems to be open too much of the time, then that will make it easier for the contents from the stomach to go back up. So this esophageal manometry can also give you a pretty good picture that is very detailed and sometimes even better than what you can see with the endoscopy. So it's sort of like a functional study of how well that lower esophageal sphincter works. And then the treatment for gastroesophageal reflux. So the first line things to do would be to try some antacid medications. For example, famotidine, which can be taken twice a day. That is an H2 blocker. Then we also have our PPIs, proton pump inhibitors, such as omeprazole, lansoprazole, pantoprazole, esomeprazole, which is Nexium. And these medications basically work on different cells in the stomach to decrease acid secretion into the stomach. So they decrease the amount of acid in the stomach. So it's important to remember that these medications are not actually going to stop the liquid from coming up. They're just going to make that liquid not as acidic and therefore not cause as much damage. And these medicines can lead to quite a bit of symptom improvement in many patients, but sometimes even that is not enough. And sometimes an issue can be that it's really that lower esophageal sphincter area, which is here. This is the gastroesophageal junction. So this is the stomach where you have all the food and the acid that is produced in order to digest the food. And this is the esophagus, and this is the gastroesophageal junction. So sometimes this area is a little bit loose and weak and allows too much fluid to go back up here. And that's when, in that case, you may need more of a mechanical solution, which is a surgery called a Nissen fundoplication. So you have a Nissen fundoplication where you take the top part of the stomach and it goes all around this area of the lower esophagus and kind of wraps it tightly, and so secures that junction a little bit better so that reflux does not go up. And it's important to do that manometry study in some cases first before considering the surgery, because depending on on some features of functionality of this area, it may be best to do a full wrap versus a partial wrap. And this toupee is a partial wrap. So you wrap it but not completely all the way. And there can be different, outcomes in the future depending on if you have a Nissen or a toupee. So it's important to have that discussion with your doctor before proceeding to a surgery like this, and to consider which one is the best option. And then lastly, the third subject that we'll talk about is feeding difficulties in general. So we've heard a lot about some of these symptoms that can all, if you think about it, can all make sense how they really can lead to a lot of feeding difficulties in DESSH syndrome. So again, hypotonia. If you have hypotonia, it's more difficult for you to sit up, to hold your head upright, and all of those things are important in order to swallow well, appropriately, and safely. Oromotor dysphagia, that's when the muscles in your mouth and throat area kind of may not function and coordinate correctly, and so that again makes swallowing difficult. If you have gastroesophageal reflux or esophagitis, that can lead to heartburn and pain in that area. And, it may be difficult for the child to explain that, but yet, they could be having this symptom and therefore not wanting to eat because of this. Constipation, if there is severe constipation, that there's so much stool in the abdomen, this will lead to, a loss of appetite, nausea, potentially vomiting and belly pain. So that can make feeding difficult. Behavioral issues, aggression, anxiety, sensory issues and oral aversion. They would like specific foods, specific brands of foods, things like that. And this feeding difficulty, it may present even in infancy, and then that can lead to failure to thrive. So it's important to work with the multidisciplinary team of doctors to overcome these difficulties and improve nutrition. So what can we do to help with this? So again, I think the most important thing in tackling feeding difficulties is a multidisciplinary approach where you have your primary care physician who just oversees everything and just kind of monitors if any acute problems or systemic worsening is occurring. You have the gastroenterologist who can think about any other potential issues like the gastroesophageal reflux, constipation, and address and treat those things. And feeding therapy, I think, is very important as well. So feeding therapy we have here, and that's when we have a speech therapist and an occupational therapist who work together on feeding skills. So basically come in every week or every 2 weeks, and the therapists work with the patient and practice the eating skills. And it's a very slow process, but it's important to be persistent and consistent and doing this repetitively, which eventually helps the child learn the proper behaviors. And then, of course, a dietitian who can help assess what are the caloric needs for this child based on his weight, on his height. And they can also assess how much fat, how much carbohydrates, how much protein, and micronutrients, macronutrients are needed for the child. They can also help, if a child has particular, likes for certain textures, what are the foods with that texture that, contain more vitamin B12 or calcium or something like that. And The other thing is, of course, behavior modification, which we heard a little bit about earlier, helping the child acquire language skills. All of those things will help all of these issues I talked about today, because it will help the child let us know what it really is that's bothering them. And then if things, are really difficult and, there's just, not a way to get proper nutrition into the child, what you can do is place a G-tube, which is a gastric tube. So this is the stomach, and the G-tube is a little tube that looks like this. It's low profile, so doesn't stick out a lot, and it goes directly from the skin into the stomach. So what you can do is you can put fluids, medications, formula directly into the stomach. So if you have a child who's refusing absolutely everything, this can be a good way to manage nutrition, fluid needs, medication administration, and that in turn can help with constipation, with acid reflux, and things like that. These are just some examples of powders that you can use to fortify calories. This is duocalin protein for the older kids, and then here it's human milk fortifier. So this can actually be added to breast milk to fortify and increase calories in the foods. And that's all I have for you today, and I'd be happy to take any questions.
So everything that you mentioned, I had gone through already, except the G-tube and the surgery. But my son was receiving speech therapy, but they discontinued 2 years ago or so because he wasn't making progress due to his dysphagia. And so we haven't, restart that therapy, because after I find out that he has DESSH, I wanted to get another input or how to go about it, or if we need to do it. Our next step was to do a laryngeal cleft repair, which he was going to have a stitch, but it didn't happen due to him being sick. But I guess my question is, how do I need to go back to, seeking that feeding therapy? Because I know that he does have the dysphagia, and he does have, the difficulty swallowing. Right now it's the liquids and anything that had liquids in it.
Yeah, so right now he's having difficulty with liquids, right? With
yes,
thin liquids.
Yes.
Yeah, so, and that's exactly what happens in patients who have a laryngeal cleft. I didn't talk about this, but this is an ENT abnormality, in the pharynx in this area. And I think it would be beneficial to have this cleft repaired, most likely. I mean, of course, you'll have to talk with the ENT doctor in more detail about, the situation in particular. But in my experience, and I've seen patients with laryngeal clefts in my aerodigestive clinic, once the laryngeal cleft is repaired, most of the time, the swallowing of the thin liquids improves. And you can subsequently monitor that on further swallow studies, like the modified barium swallow study. Usually the ENT doctor gets that study after the repair, probably a few months after the repair, and they look for improvement, and so no penetration or aspiration with the thin liquid. So I would suggest, yes, maybe it would be more beneficial to go back to the speech therapist and feeding therapist after the cleft is repaired. But I am of the opinion that I think it's always good to go to these therapies. I know I've seen many times when kind of feel like you don't make progress, but I still think that even if you feel like you're not making progress, I think it's still good to continue to go, and because maybe then you will make progress. Or what if you stop going, maybe you may regress possibly a little bit, So I in my opinion, I think yes, it's good to go back. Yeah, I think in your situation, I think, since there is something that can be done, I think I would go back after the repair. Yeah. Mm-hmm. Mm-hmm.
Hello, doctor. The medications used for treating ADHD, the medications that we use for treating ADHD, they can cause constipation and dryness in the mouth. So these side effects go away when we stop the medication. So in general, what are the ways to handle these side effects? These are medication-induced constipation and...
Yeah, that's a good question. Yeah, it's very common. And this happens very often, but my suggestion would be to, as much as possible, try to use the Miralax, the Senna, and basically manage the constipation in that way, and make sure that, your child, you can first start with increasing fluids, increasing fiber. If that doesn't work, Miralax, Senna. And it's important to be consistent with that, like every day, because if you miss a dose here or there, it can sort of offset the constipation, and it can get intermittently a little bit worse, and so repeatedly that can lead to a significant problem. And if not, then the anal Botox and things like that.
So kind of to piggyback on that, are you aware, I'm sure you're aware, Miralax actually recently came out with Mirafiber gummies. And we have started substituting those instead of the Miralax for an everyday, and it has made a huge difference.
Yeah, and I didn't talk about this, but of course, one of the drawbacks of Miralax is that you need, for 1 cap, 8 ounces of liquid, and that can be a lot of liquid for a child, especially if they don't feel like drinking that or don't want to drink that. That can be hard. So there are other things like these little chews like that, which is great to use. There are also these Dulcolax over the counter. You can buy Dulcolax chews. The Senna chocolate, and then, the Dulcolax chews are fruit flavored, so some kids like those, but anything helps.
I think this will be quick. You might have said this, but there's been so much said that does, like the Miralax, does that, after a while, does your body build a tolerance to that, and you need more?
Yeah, that's a common question. So no, it doesn't. Your body does not build a tolerance to it. But I think some parents may get this impression because perhaps the Miralax starts working, and when you give your child Miralax, they take it and it works and it absorbs more water from your body into the colon, and then once that stool passes, you need Miralax again in order for that to occur again, in order to make the stool soft again. So it may seem like your child is dependent on it, but it's not an addictive medication. Like, we don't believe that that's what's happening.
Thank you so much.
Yeah.
So this is a new speaker and a new presentation that we're having this year because so much happens on our WhatsApp chat. And we try to sort of understand what we can about genetic reports and what our reports are telling us about our child and DESSH. And there are people with certificates for this for a reason, because it's extremely difficult to decipher. And so we have brought our genetic counselor to come and speak with all of us today to answer some of those tricky questions. So I believe she will share a bit and then hopefully leave room for some questions. Thank you. This is Erin McRoy.
All right, good morning. Thank you so much for the opportunity to come and speak with you all and talk about genetic testing and how to read those reports. We will go ahead and get started. So the agenda today, we're going to talk about the basics of genetics, just a quick refresher. We're going to talk about the components of a report, talk about the types of results that you may see and what they mean, and then how the reporting and the genetic testing can actually go beyond us and lead to further research in the future. Alrighty, so just a quick biology refresher. So the human body is made up of these microscopic structures called cells. And we have trillions upon trillions of cells that make up our bodies. Within our cells, we have our genetic code, and that's something that we inherit from our mothers and our fathers. It's contained on these structures called chromosomes, and I like to think of chromosomes as like books on a bookshelf. So you have the chromosomes that are the books, and then you have the genes that make up the book. So each chapter represents a gene. And each gene makes a protein. And proteins are what go out and do all the important jobs and functions in our bodies. Does this sound familiar? Maybe biology class a while back? Yeah. It comes back, I tell you what. So we know the gene that is associated with DeSanto-Shinawi syndrome is called WAC, and it is located on chromosome 10. Now, you may often hear a variant. What is a variant? Well, a variant just refers to the specific change or alteration in the genetic code. You may also hear it called a mutation. And there are many different types of mutations or variants that are associated with DESSH. And I'll probably use variant and mutation interchangeably, just so you all know. And this is a representation of what our chromosomes look like, you know, those books in the bookshelf. So we have 46 chromosomes in total. We have 23 different types or 23 different pairs of chromosomes. And we inherit one set of a pair from mom and one set of a pair from dad. And so that means that we inherit 2 copies of chromosome 10. 1 copy of chromosome 10 from mom and 1 copy of chromosome 10 from dad. Now, this is something I just want to clear up because I hear this a lot in my experience as a genetic counselor. I often hear things like, I tested positive for the gene, or I tested negative for the gene. We actually all have the WAC gene. We actually all have 2 copies of the WAC gene most of the time. It just comes down to what version of the gene you have. So if you have DeSanto-Shinawi syndrome, you have a version of the gene that contains some sort of spelling change or typo or mutation or variant, in other words. Now, DESSH can be diagnosed by a few different types of genetic tests. The first one being what we call a panel, which is a select number of genes that can be associated with a particular symptom or set of symptoms. So things like developmental delays or neurodevelopmental conditions, you know, there are lots of genes in our genetic code that can be detected by selecting a few different genes or maybe a few hundred genes to include on that panel. We can also have something bigger called whole exome sequencing, which actually looks at all 20,000 genes. This is often ordered when there is a large constellation of symptoms or features that could not be narrowed down to one specific panel. And then we also have something called a chromosome microarray, which looks for larger changes within the chromosomes themselves. So chromosome microarray looks for larger deletions or duplications of genetic material, kind of like if you were looking for any extra or missing pages in a book. Whereas the exome and panels look for smaller changes like typos, letter alterations, sentence alterations, and things like that. There's also different ways to classify genetic variants. So when you see your genetic report, you may see something that says likely pathogenic or pathogenic. That refers to the fact that we have enough evidence, or the researchers and all the scientists and researchers out there have seen this particular spelling change or alteration in the gene enough to know that it impacts the function of the gene and protein and that it is associated with symptoms in somebody. You also can have the other end of the reporting, which is likely benign or benign. That means that there is enough evidence, we've seen this enough in healthy people to suggest that it's not likely causing symptoms or features of a condition. And then you can have this middle one here called a variant of unknown or uncertain significance, or a VUS or VUS, we call it a lot. These are actually quite common when we do genetic testing. There is still a lot that we are learning and understanding about our genetic code to this day. And sometimes if we identify a change that we just don't know what it means or haven't seen it enough, we label it as a VUS in the hopes that maybe we'll learn more about it someday. Now, there are lots of different components to a genetic report, and these may vary depending on the lab and the testing method used. The gene or transcript, that refers to the specific region of the genetic code and its location within the genetic code. And I'll be showing some reports for some examples and some reference. The variant, like what I mentioned, is the change within the gene or chromosome and the subsequent impact on the protein. So that's important to remember. The genes provide the instructions, but the proteins are what actually carry out the job and role in our body. Zygosity or inheritance. So this refers to knowing whether a particular variant is present on one or both copies of a gene or chromosome. And do we know if the gene or variant was inherited from a parent or if it's brand new in the child? The disease or condition refers to what associated diseases that are known to be due to changes within that gene. So the WAC gene, we know that changes in this gene cause DESSH, DeSanto-Shinawi syndrome. The inheritance pattern is how a condition is passed down in families. So do we see this skipping generations, or could we see this in every generation? The population frequency refers to how often we see this particular gene variant in healthy people of the general population. This can tell us if something is more rare or if it's more common. It could suggest that it's not as harmful if it's more common, versus if it's more rare, that can suggest to us that it is likely a causative variant of disease. And the classification is like what we mentioned earlier. You can have benign, likely benign, uncertain, likely pathogenic, or pathogenic. So this is one example of a report diagnosing DeSanto-Shinawi syndrome. So as you can see here, we have the gene transcript, and you can see WAC is the gene. This NM is the specific location of the gene in the genetic code. This is what the researchers and doctors use to look at and examine the gene in our genetic code. The variant details. So the first one here, that refers to the specific variant or change within the code itself of the gene. This P dot here refers to the subsequent change within the protein. And then this one here, this ClinVar ID, ClinVar is a database that we use to evaluate the significance of a particular genetic change. So the zygosity or inheritance. Heterozygous means that it is present on one of the two copies of the WAC gene. So you have one copy of the WAC gene that has a spelling error and one that does not. De novo means that this variant was not found to be inherited from mother or father if they're involved in the testing. And we'll get into more about how de novo changes happen and some caveats with de novo results. The disease or condition, there we go, sorry, that's the de novo change. So de novo changes can happen a few different ways. They can happen very early on in development. So after egg and sperm combine to form the embryo, there can be some random change or error in the DNA replication, and then that can subsequently be spread and passed down to all of the other cells that go on to develop the fetus. It can also happen in the germline of the parents. So germline just refers to like the egg or sperm cells that go on to create an embryo and a fetus. So sometimes it can be due to a single change or single alteration within a sperm cell's DNA, or a single alteration or change within an egg cell's DNA. Now, when we think about de novo changes, we think, okay, this represents the first person in the family to have this condition. We think, first person, maybe the last person to have it. Something we have to consider is that if you have multiple kiddos in a family, like siblings who have DESSH, and both parents tested negative with their own testing, that can be caused by something called germline mosaicism, in which some egg cells contain a spelling change or some sperm cells contain a spelling change. But that type of change cannot be picked up on the traditional testing we do. Show of hands, for those of you who received the diagnosis through the genetic testing, how many of you submitted samples alongside of it as mom or dad? Yeah. So that is due to the fact that we know sometimes changes can be inherited, or sometimes they can be brand new, but this also can help us figure out if there is any chance of having another child with DESSH as well. The germline mosaicism is really hard to test for. Sometimes we only know about it until after another kiddo is born in the same family with DESSH. Okay. Now, the disease and inheritance pattern. The gene that we know, WAC, causes DeSanto-Shinawi syndrome. Autosomal dominant refers to the inheritance pattern, or the mode of inheritance. And this MIM number, this just refers to another database that provides all the symptoms and knowledge and papers that we have about this particular genetic condition. And then this is autosomal dominant inheritance. So because you have one of two copies of the gene with the spelling change, that means that there is a 50-50 chance to pass it down to future generations. And it affects males and females equally, so this is not sex or gender specific. We see kiddos with DESSH who are male and female, and there's no reason why maybe a male or a female would be more likely to have it. It's a random chance, 50-50 chance. Okay. Now, this population frequency, as you can see, NA, not available or not applicable. This tells us that this particular gene variant, or this mutation, is not seen a whole lot in the general population data, which tells us it's rare. And rare means likely related to a condition. And then pathogenic refers to the classification that we have sufficient evidence to suggest that this is impacting the function of the gene and protein and causing symptoms in an individual. Okay, so here's another example of a report. So this one is actually a different type of mutation or variant. It's actually called a copy number variant, or a CNV. And this particular report tells us that this is a deletion within chromosome 10. So it's actually missing more than just a few letters. It's actually missing a substantial amount of information. That includes the WAC gene. And this particular part of the report here where it says sequence GRCH38, this is basically giving us the coordinates of where the specific deletion is occurring and the breakpoints, the stop and end points of this deletion within the genetic code. This part here, this 110.72 kilobases, tells us the relative size of the deletion, basically how much of the DNA in our genetic code is missing. You can see here, inheritance unknown, not maternal. This means that with this particular case, the mom was available to submit a sample, but dad was not available. So whenever you do something like whole exome sequencing or chromosomal microarray, you may have mom and dad send in samples, and they look for that specific variant or mutation in the parental samples. So they determined that mom did not pass down this genetic variant. She does not carry this variant. But because we didn't have dad's sample to compare to, we cannot make the assumption that it was brand new in the child, because we would want to verify if that did come from the father, but we can't verify that. So sometimes you'll see the inheritance pattern is unknown. Again, pathogenic, meaning it's sufficient evidence to be associated with DeSanto-Shinawi syndrome, and then the condition is there. This is another type of result. So just kind of showing you the different types of changes that occur in our DNA. So in this particular report, we see that the variant is the C.451 C to T spelling change. So this is what I use to talk with patients through, what does this exactly mean? If we think of our DNA is made up of 4 letters, and the specific sequence or pattern of letters carries a lot of importance to how well the gene and protein works and functions. If even one of those letters is misplaced or swapped for another letter, in this case at gene position, letter position 451, this case it was a C to a T, we know that that particular letter swap, although it's so small, it does play a big role into how the resulting protein functions. In this case, it actually causes the protein to be shortened. The whole protein doesn't get made. And so that is one of the mechanisms that we know can cause DESSH syndrome, is the protein doesn't get made fully and it can't do its job properly. Here's another example. In this case, you can actually see that a few letters were deleted. So it's not just a single letter swap, it's actually a few letters were deleted from the code of this gene. And what happens is everything that is downstream or after that deletion gets shifted over 2 spots. It's kind of like if you're reading a book and a few letters were deleted from a sentence, well, that entire sentence then gets messed up or misread when you read after those 2 letters. So this also can cause the WAC protein to not work properly. You can also have larger changes, larger variants or mutations within the chromosome 10. In this case, you have a deletion within the chromosome. So this is chromosome 10 here. The P arm just refers to the smaller arm of the 2, P for petite, and then the Q arm refers to the larger of the 2 arms. Q just follows P. Q doesn't stand for anything. So the specific location of the WAC gene is within this band here on chromosome 10, this band 10p12.1. So we know that this gene is located within this band, within this location. Some cases of DESSH, they actually have a deletion that includes WAC gene, but also other genes within this region. So as you can see here, these are some of the other genes or some of the other instructions that are within this band. And so if you have a larger deletion that includes more than just the WAC gene, you can see different symptoms or more severe symptoms than other patients with DESSH. So it's important to think about that. A deletion is considered a mutation. It's a different type of mutation. There are lots of different changes and alterations we can have in our genetic code, but they're all called mutations. Now, your report does go beyond you, believe it or not. Different genetic mutations in this WAC gene have different impacts on the protein function. So like we talked about the different types of changes we can have, the different reports that have come up. It all depends on where in the specific location of the gene this change happens. We know that some areas of the gene, some areas of the protein, play specific roles, and if those areas are damaged or altered, it can have a specific impact on the function of the protein. We also know the specific type of mutation can have a difference as far as how that protein works and functions. We know new mutations are being discovered because they are occurring in these hotspots or these areas of the WAC that are susceptible to mutations. We're discovering new changes every single day. Research is being done to see if certain symptoms or features of DESSH are more likely to be seen with a certain type of variant or mutation. So this is being done through databases and patient registries. I know DESSH has a patient registry. I know Dr. Shinawi is doing research on this as well. And then the aim is to provide more tailored information to you all, to family members about what to expect. If we can determine that some kiddos may be more susceptible to XYZ because of their specific mutation, you know that can impact care and management going forward. And then we are also doing research to lead to new treatments or therapies for DESSH syndrome as well. Now, these are just the references I used, but I wanted to see, do you all have any questions about what we've talked about? Yeah.
On one of the slides, you referenced the size of a deletion, in like kilobases or something. Like, how do I reference like what that means? How many kilobases would there normally be? Like, is that a big one or a small one? Like, I don't know how that, and is every gene or is the WAC gene a different size than another gene?
Yeah,
You know what I mean?
that's a great question. So certain genes are bigger or take up more of the genetic code than other genes. This 110 kilobase, you know, you think about it relatively speaking, kilobases are smaller than megabases. And megabases refers to a larger type of deletion. So if you see something that says megabases, like 1 megabase is actually bigger than 110 kilobases. And so that's something that your clinician, your research team can look into further to see, okay, if this is a bigger deletion, what exactly is missing because of this bigger deletion, or what area of the WAC gene is missing because of that? Does that answer your question? Okay, perfect.
And also, What would a report read if the entire gene was missing? What would it look like on your report?
Yeah, so it would likely look very similar to this. Now, if you were doing whole exome sequencing or panel testing, it would likely say entire gene deletion or gene deletion. So then the doctors and the geneticists and the genetic counselors will say, well, let's figure out the exact breakpoints of that entire gene deletion. So there are different methodologies for different tests as far as how much information they can tell us, what they can pick up on. And so a panel test or whole exome sequencing doesn't give us the best information about deletions or duplications in our genetic code. They just tell us, hey, we don't see the signal for this gene. The whole chromosome microarray, though, is much better at picking up on the specific breakpoints. What particular page does this deletion start on? What page does it end on? That is something that may be done. You may have one genetic test and then another genetic test to clarify the result. Yeah, okay.
Hi there. I think you referred to as germline mosaicism. Is that, can you pass that to a child who doesn't have DESSH?
That's a great question. So germline mosaicism, just as a refresher, is when you can have multiple sperm or egg cells carrying the WAC, the WAC genetic change. If you have a child who doesn't have DESSH, then they did not inherit their DNA from an egg cell or sperm cell that had that genetic change. They inherited their DNA from an egg cell or sperm cell that did not have that genetic change. And so we would not be concerned about that child having germline mosaicism themselves. They would be, they would not have symptoms, and we would not be concerned about them passing that on to their children. Basically, a germline change means that it's present throughout your entire DNA. And so if you don't inherit anything in the egg or sperm, then you should be okay. You shouldn't necessarily pass that on to future generations yourself.
I don't know about other people's genetic reports, but ours says it's a nonsense variant.
What is a nonsense variant?
Yeah, it feels very insignificant compared to what we're dealing with, and I'm like, oh, all this for a nonsense variant?
Like,
it's hell.
So, yes, going back to this slide here. So, a nonsense, actually, let me go forward a little bit. I think it was this report. Which report was it? This one. Okay, so a nonsense variant refers to the specific impact that a mutation within the gene has on the protein. So a nonsense variant means that the protein production stops abruptly. It's very much related to what goes on in the gene and molecular level, but we know that there are certain signals in our genetic code that signal the start of protein production and the end of protein production, and those are within the gene. If you have a building block that makes the protein, if you have a building block along the way that is instead changed to a stop sign, like a stop point, then the rest of the protein doesn't get made. And so you can have a shortened protein, you can have a non-functional protein because it didn't get fully made. So that's what nonsense means. And I know the terminology, the nomenclature, doesn't reflect what the report necessarily means. Like nonsense, well, there's different ways to interpret that. We can also have something called a missense genetic change, where actually one building block is switched for a different building block. So the protein gets made, but the building block that is supposed to be there in the protein is switched for a different one. And that can cause the protein not to fold or shape properly, and then the protein can't do its job properly. And then another type of genetic change we can have is this one here called a frame shift genetic change. And a frame shift just means that you have a deletion of one or two letters, and everything after that is shifted a place. Like I gave the analogy, if you're reading a sentence and a few words or a few letters are deleted or added, that means everything that came after that deletion is altered. It's like altered a space or shifted a space in what we call the reading frame. And that can also lead to changes in how the protein folds and functions. It can also sometimes lead to a premature stop position as well within the protein. So those words, nonsense, missense, frame shift, those all just refer to how we classify what we call the specific changes that occur.
Can the protein be synthesized, the missing protein, can it be synthesized to supplement What's missing?
So that's a potential therapy that is being developed. Have you all heard of gene therapy before? Gene editing, yeah. So that is currently an area of research that has been established for a few different genetic conditions. You may have heard of things like spinal muscular atrophy or retinitis pigmentosa. Those types of conditions, they have developed that therapy for. It is not available for a lot of other genetic conditions, but I believe that is something that could be on the horizon since we have established that for a few different genetic conditions. Could we do that for DESSH in the future?
With the data that we have today of the DESSH patients, do we know if the severity is uniform when you see missense, nonsense, and frame shift mutations?
So you said what is uniform?
The severity of DESSH condition when you compare it with the type of mutation.
Yeah.
Missense, nonsense.
Oh, what symptoms may be associated with nonsense versus missense?
Yeah, the severity of symptoms.
Severity.
Is it uniform with the current data?
Gotcha. Yeah. So Dr. Shinawi may be the person to answer that. Sometimes.
Maybe. So this is what we call the genotype-phenotype correlation. And I showed some of the data regarding the frame shift. But for the other mutation, I couldn't find any correlation between the symptoms and the type of the mutation. But again, maybe this is related to the fact that we have small numbers and emphasizing the fact that we need to recruit more patients actually to get larger cohorts and to do statistical analysis. So the cohort at this time is 101, and the aim maybe in the future to get to maybe 200-300 patients, so we can get statistical significance when we do this type of analysis. The most common mutation is the frame shift, which is found in about 50% of the patient. And you notice on one of my slides, this is the only mutation that we were able to find this correlation between the phenotype and the genotype. For the other types of mutations, it's really, we had small numbers, and it's really difficult really to determine this correlation. No, I didn't get. Okay. That's correct. Yes. Yeah. Yeah. If you have any specific questions regarding the mutation in your child, definitely we can discuss it. Yep.
And that goes back to the research that's being done to see if we can determine the impact on the protein and what symptoms they can or cannot cause. That's an ongoing area of research.
Hi, I just had a quick question. I just wanted to clarify, is there any reason, there's no reason for siblings to test if they don't have DESSH?
If the parents came back as negative and the siblings do not have symptoms of DESSH, then most likely we would not have to test them. I say that hesitantly because we know some genetic conditions can be very mild, like the symptoms can vary between the parents and the children and the siblings for other conditions. But for DESSH, I don't believe that we would see symptoms if the child had it. So yes, I don't believe there would be a reason to test the children if they don't have DESSH, they don't have symptoms.
Because according to the graphs, and it seems like every single one of us, the DESSH patients have the facial features, right? So then if, I'm sorry? Right, but if all of them have the facial features, I don't know. I guess I'm still a little bit like, do we need to? I just guess I'm not, my question's not answered.
Yeah, that is a great question. For purposes of, family planning and just wanting to make sure for other people in the family, I mean, certainly we have ordered testing for siblings. Now, it also comes down to, will insurance cover it? Sometimes insurance will cover it and sometimes they won't. And so we also got to think about, okay, other risks, rewards of doing genetic testing, would this be something that could impact eligibility for like life insurance, stuff like that someday? So there's a lot of factors to consider if you're trying to figure out if someone in the family should have genetic testing. So it's a lot of access factors, yeah.
Depending on your hospital, like when our son was diagnosed, they offered it for free
Mhm.
for other kids, and then apparently for a certain amount of time.
Yes.
They're now encouraging it for maybe other family members, and they were like, it's past the allowable time for us to do it for free, but we can go ask and get an exception to that, and so they're likely to do it for free for other family members.
Mhm.
So I think the point is to go ask the hospital, they likely
Mhm. Yeah.
Mm-hmm.
Yeah. And again, some labs are more willing to do that than other labs. Some hospitals may be more willing to do that than other hospitals. But yeah, that's a great question.
Good afternoon, everybody. I just have just a quick question, real quick. I don't know if you might have answered this, but I just wanted to make sure.
Yeah.
So my question for you is, what would happen if not only was the WAC gene that was missing, but other genes in general? And what would be the treatment for those? What would follow?
If there were other genes missing or other genes impacted?
Yes.
Yes. So that is very much dependent on what genes are missing, how much of them are missing, and if there are any interventions or treatments available for those other genes. Interventions and treatments can vary based on the gene that's impacted, and so there may be additional supports needed or additional doctors needed depending on if another gene is missing or deleted. Like if that other gene causes symptoms outside of DESSH, then we would want to have you see maybe another doctor or get additional supports or help if the other genes were missing. It's very much case dependent.
Thank you so much.
Yes, it's a great question.
This is from online, and it's probably more a Dr. Shinawi question. Are there any children with exact same mutations in their results, and are there similarities in their behaviors? Because you just showed one and it wasn't my son's.
Yeah, I think I didn't have time really to go over the mutations and the correlation between the genotype and the phenotype. So first of all, we have a recurrence of certain mutations at position 151. This is one of the mutations that Erin just showed. I think the previous slide. So this is one of the most common mutation that we have. Another mutation is at position 513. We tried actually to compare patients with exact same mutation to see whether they're exhibiting exact same clinical manifestations. To some extent, I would say yes, but it looks like there are additional factors that are affecting the clinical manifestations. So this is not as simple as you would think, that two individuals with the same mutation would exhibit exact similar findings. It looks like there are additional genetic modifiers. I was talking also about gender differences between boys and girls. So this is the question, or any other? With the recurrence, there are, I believe, 7 patients with the 151 and 3 or 4 patients with the 513. But the remainder of the mutations are very unique, which means there is no recurrence in other families.
Do we have to? I can do one more. That's fine. I'm good. Yeah.
I'm just wondering, so just to be clear, what is if people have questions on their particular variant and things,
what I know we're not meeting with Dr. Shinawi. We're meeting with the genetics team on Friday. What is the best way? Should we be emailing Dr. Shinawi? Should we talk with the genetics? What's the best way to go deeper on everyone's individual? Okay, so just for people online, anytime you can communicate with Dr. Shinawi on that. Thanks.
All right, everybody. I'd like to introduce Dr. Harrison Gable. He is a member of our medical advisory board at the DESSH Foundation. He has been assisting with us since the beginning, and we are so glad to have him here to speak. In the past, he's been able to do overviews of his specific DESSH research. There will be time for that, but today we wanted to really discuss pathways to treatment and how we can really get from a rare disease diagnosis to a treatment. And that's something that we're going to look at today through the lens of basic research and scientists and different types of studies that can lead us from here to better treatments for our kids. So without further ado, Dr. Gable.
Great. Thank you, Caitlin. As Caitlin mentioned, we're going to sort of dive into research now with an eye towards, what does research do for trying to find therapies? It can sometimes be, you hear about all these mice and cell lines and sort of how is that going to turn into a treatment for DESSH? Just a little bit more introduction about myself. I'm a PhD researcher, so I'm not a clinician. I can't give you advice on treatments. However, I work with multiple rare disorder groups, and I'm thinking at the intersection between basic science and how does that lead to therapy? So things like emerging therapies is where my expertise is and why I'm giving this talk today, because we're sort of thinking about how therapies are going to emerge. What we wanted to do before, we're going to have a few discussions and a presentation about where we might be in terms of the basic biology of DESSH, sort of what goes wrong when the WAC gene is disrupted, and then where a therapy might be emerging. But we wanted to give you sort of a roadmap of how does this all come together. So I'm going to give you a quick overview of how does basic research and clinical research add up to testing therapies, and then how do they get approved? Now, it's a broad overview. You could go for a very long time in each of these, so I'll try not to overwhelm you, but I'm also happy to answer questions, and we'll have a panel where we can talk about it more. And this is the basic, very simple roadmap, although it could be considered a circle as well, where we do basic research about the disorder, understanding the disorder. That leads to ideas about where we might come up with therapies, because we learned enough about the disorder and about the WAC gene, for example, to know what we might do for therapies. And then after we come up with those ideas, we have to put them through clinical trials to make sure they actually work and that they're safe. Well, safe first, efficacy second. Now, underneath that very simple roadmap is a lot of research and development that happens, and I'm going to take you through this roadmap overall and sort of what each of the aspects are, but I wanted to put it all in front of you so you can understand how research leads to therapies. There are multiple rare disorders that are all going through this same process. What's interesting about rare disease is that each rare disease has its own specific challenges, but if it's a genetic disorder, most rare disease organizations like yours and like ours, I should say, because I'm part of the DESSH Foundation, and other foundations are doing the same things, trying to advance these things. And we can learn from each other, and the great thing is advances, for example, in gene therapy and other disorders can be brought over to DESSH eventually, we would hope, so we don't have to reinvent the whole wheel. Rett syndrome, for example, that I work with the International Rett Syndrome Foundation, is way out in front on gene therapy, and a success for Rett syndrome is a success for DESSH. Right? The possibility that we would be able to do gene therapy gets higher if they solve that problem, because the way we deliver genes is actually the same potentially between the disorders. So these are all interconnected between disorders. So this would be the sort of basic flow chart of what we would do. Let's start with basic research. Why do we need to do basic research? Well, to break it down, the first thing we need to do, and the reason we're all here, is because a physician who sees enough patients recognizes that there's a disorder that has common symptoms, and that's Dr. Shinawi, who basically identified patients with reoccurring facial gestalt and realized this could be a syndrome, and then started thinking about, well, what's the underlying cause, a genetic disorder, and identified the gene. So the first thing we need to do is define the disorder, and this is these initial studies to say, here are patients with similar symptoms, and then what are all of those symptoms? Now, Dr. Shinawi is doing that, and he has a cohort of 101 patients. He's telling you more and more about what the disorder looks like, but the patient registry, where you provide your own data, right, where that all gets put together, that is invaluable for understanding what this disorder looks like, and will actually be very important for testing if therapies work. So we'll get to that in a minute. So you're really a part of the research if you're reporting that information. So please continue to be involved in that. One aspect of that, which basically Dr. Shinawi's study is executing, is what's called a natural history study. It's literally the progression of a disorder over the course of the time that a patient has it, and you track many individuals to know what the disorder does, because in a developmental disorder such as DeSanto-Shinawi syndrome, there's actually, people change over time, and we need to know what that looks like, and we need to record that. So a natural history study is really sort of what's the course of the disease if you don't have interventions, and that's really key to understanding, again, if treatments work. So that, Dr. Shinawi's been leading this charge, and we're learning a ton about DESSH, and we'll continue. Now, to understand the underlying biology of what's going on, you need the gene, right? And we just heard beautiful talk explaining in lots of detail, which was great, that, what the gene is, and I'll touch on that in a second. If you identify the gene, then because we've been studying molecular biology of cells and the genes and functions in cells for decades now, we can immediately take all that information and apply it to understanding the disorder. And that's where folks like me and Dr. Vogt and Dr. Kim come in and start studying the underlying biology of the gene. And that gives us clues as to how we might do therapies. So what do I mean by that? Well, it's great. You have review. It's always good to review after you get introduced to something. So we now I won't make it a quiz, but here's essentially, the idea about the WAC gene. So we've identified the WAC gene is disrupted in DeSanto-Shinawi syndrome. The DNA encodes the gene. We have the ATs, Gs, and Cs, and then we heard very nicely about how the WAC protein is made from the WAC gene, right? And we now know that variants, changes in the DNA, basically break the WAC gene so that it can't make the WAC protein. Okay, so that's the cause of DeSanto-Shinawi syndrome. Why does knowing that cause help us? Well, if we can understand what this protein is supposed to do in cells, we can think about what's wrong with those cells, and we can think about coming up with a therapy that would correct that. Now, that's what's considered a rationally designed therapy. It's not just treating symptoms that you see, but instead understanding the root cause. I mean, we know the root cause now. That's a huge advantage for us, right? But now we have to think about how we can correct things as close to the root cause as possible. So how do we do that? Well, if we think about DeSanto-Shinawi syndrome, it's caused, just as, again, review and hopefully helpful for you guys to see again, everybody has 2 copies of the WAC gene. If you're unaffected, both of those copies work. If you have DeSanto-Shinawi syndrome, one of those copies is broken. So this is the DNA sequence, and that leads to too little of the WAC gene, WAC protein, inside cells. And I'm just giving you an advanced hint about what the WAC protein might be doing. We think it works in the nucleus of cells. So if we need to understand what WAC does, we need models. We need to be able to study in experiments what the WAC gene and then the protein that it makes is doing. And the way we do that is we either use human cells, model in a dish, essentially, where we can isolate cells from individuals with DeSanto-Shinawi syndrome versus not, or we can use animal models, because due to evolutionary conservation, the fact that mice and us are very closely related in our DNA sequence, mice have nearly the exact same WAC gene that we have. And over and over again, for generations now as scientists, we've found that if you study what a gene does in mice, you learn a ton about what it does in human. Now, not everything. There are differences, and that's what makes us different. But we can use a mouse model or even a zebrafish model that Dr. Kim, who's a researcher on our advisory board, uses. So zebrafish have a very similar WAC gene. So we can study those mice in the lab. We can do experiments with them. We can really dig deep into what's wrong with mice that essentially we've made a mouse that has DESSH, and we can understand what's going on with that mouse to understand what the WAC protein does and what goes wrong when it's lost. So this is how we dig into the disorder and understand what might be going on. Now, what's one of the first things we want to do is understand what that protein does. And you might be wondering, well, why is that important? Well, that's the root cause of the disorder. If you know what the protein does and what's failing to happen, inside cells, then you know what's causing the disorder at its most basic level. And what that function is can really change what we think about for therapies. So we use these models to study what WAC does, for example, inside neurons, because we know that there's a lot of cognitive and behavioral issues in DeSanto-Shinawi syndrome. And there's a lot of possibilities. I'm putting several possible functions of this protein inside cells that we might want to rule in or rule out. For example, it could help neurons with their electrical properties. It could be like on the membrane of cells and helping the neurons sort of communicate with one another. It also might be like an enzyme that sort of converts things inside cells and helps the cells function. Or it could be inside the nucleus of the cell, helping the cell decide what other genes are turned on and off. Now, each of these possibilities would lead to a potential strategy for how you might treat the disorder. If it was about cell-cell communication, we might think of different drugs and different strategies for treating the disorder than if it's one of these other things. And in the work we've been doing so far, we know that at least one function of the WAC protein is that it's inside the nucleus, helping to turn other genes on and off. This rules out certain types of treatments in terms of directly addressing what's wrong with WAC, and rules in other types of treatments. So it really gives us a guide for where we might go with therapies. The other thing we can do once we make animal models is we have basically a testing ground where if we come up with a therapy, we can see if we can make the animal version of DESSH better. So Dr. Vogt and Dr. Kim have now been studying the animal models we have and characterizing what's wrong with those mice that have DESSH, and we find commonalities between the mice and the humans. A mouse is never going to replicate individuals with DESSH, but we can see that changes in craniofacial development occur, that there are behavioral deficits that sort of aren't, it's not human behavior, but it shows that the function of the brain is altered. MRI analysis can be done to see those structural changes that we talked about. And then I won't get into the details, but we can also look at the genes that get turned on and off. If WAC's job is to turn on other genes, we can measure all of those things. And each of these things can be a readout to, one, understand what's wrong in the disorder, but also if we get a candidate therapy, we can give it to the animals and see if these get better. And that's a testing ground to see if this is a good idea to go ahead with patients. So the idea of going ahead, and coming up with ideas. So let's say we're executing all of this work. How do we move on to therapies? Well, there's sort of two classes of coming up with new therapies. And I'll actually talk about the bottom one first. But at the top here, we have just using drugs that we use to treat the different symptoms that the individuals have. Doctors now, as we've heard about, have come up with drugs that say, we have a drug for anxiety, we're going to try this for you because it's indicated. The drug is already meant to be used to help the patient. There's also the potential, and I'll talk about it at the end, of off-label drugs that are not meant for that particular symptom or for treating the patient sort of with the way they're presenting, but maybe they'll work if we have reason to believe it will work. Now, the other way, which is harder, but perhaps better in the long run, is to use the information about exactly what WAC does to come up with what we call a rational therapeutic, something that's meant to either fix the gene or replace exactly what it does. If you could do that, you address the root cause of the disorder, and you have what's called a disease-modifying therapeutic. It actually stops the process of the disorder happening, and that would be preferred over sort of managing symptoms with lots of different drugs. So briefly, and there's lots of areas we could talk about here, one of the big areas that's gotten a lot of interest recently and is going ahead, for example, in Rett syndrome, so I mentioned if there's success there, it sort of paves the way for us with DESSH, is gene-targeted therapies. This is the idea that you would replace the function or somehow fix the function of the WAC gene, and that could help all the cells in the body get better if you replace the gene. So what this looks like is if you have an individual with DESSH, they're missing one copy of the WAC gene, right? That one functional copy due to some of those changes that were talked about, and they have too little WAC protein. In gene therapy, the idea is you deliver a second copy of the gene, or you go in and fix the broken copy of the gene. This is done, the most common way that people are trying it now is actually to deliver the gene using a virus that is for the most part, we hope, inert, and can get into the brain, for example, and deliver the gene. This would put back the WAC protein and really fix it from the bottom up. So this could be quite an ideal treatment. Now there's lots and lots of challenges here. We have to get a virus that can get into the brain. We have to put back the gene at just the right levels. But as I said before, we're moving on these types of therapies across rare diseases, including neurodevelopmental diseases. So every advance that happens in another disease sets up the methodology to use it in our disorder. So the great thing is we can stand on the shoulders of those giants and hopefully be there faster. But it is, once you come up with this idea, you have to test it. And where we would test that first is in mice. That's why it's great to have mice, which we've established have very sort of some things really in common with individuals with DESSH, because we can treat the mice with the virus and see, do we make them better? Is it safe? Is it effective? And that sets us up to be able to then go into clinical trials eventually with patients. This is not happening soon, unfortunately. We're talking probably a year's time scale before we're doing gene therapy, but the field is accelerating at a remarkable rate of speed. And there was a New York Times article about a particular patient we could talk about where they corrected their gene with a different type of gene therapy. And the field is having these successes, and hopefully it just keeps accelerating. That's the sort of the big win. And there's also the potential for sort of screening for new drugs using what we know about WAC. I'm not going to go into more detail about that. But I also just wanted to touch on this idea of sort of off-label or finding new drugs in the existing pool. The idea here is that if you could find a drug that has that would help for DESSH, and you just don't know you're supposed to prescribe it, if that drug's already approved and has already been shown to be safe, that could be a much faster way to treating the disorder. Now, the downside is these are drugs that were developed not to specifically treat DESSH, so they're not rationally designed. We have to somewhat get lucky. Now, you're going to hear a little bit about some work being done at the Mayo Clinic where they're starting to see some evidence that there might be a path forward here. So we wanted to address it, and of course, it's the best thing to do if you can act fast. Even if it's not the sort of perfect rational design, it could be something that we could get going sooner rather than later. But it also needs to be investigated just like these brand new therapies to make sure it's safe and effective. So what does this look like? We'll likely hear more details about this, but in this case, you take an individual who has DESSH, and then you could, for example, compare cells take DESSH cells and either have them with or without the drug. And in the study we're going to hear about, they actually looked for drugs that were known to already work and be prescribable for other disorders, but looked to see if it's possible that some of them might actually just make the WAC protein come up more. Now, this is not a rational design. It's just to look to see if in databases there's evidence that this will happen. If you get a hit, you can then bring it back and try it, right? Now, the upside of this is that you can actually, if it's an FDA-approved drug, you can go ahead and, in what's called off-label use, try the drug and see if it works. So we'll hear more about this. It's really a great opportunity. And then the challenge is to say, is it effective? And initially, an off-label use can be done either by physicians without them testing it as a sort of a catch-all drug. It's just, I'm going to try it for you as my patient. And as long as it's approved by a certain amount of review, they can do that. But if you want to turn it into a therapy, you actually have to then go and validate it with large numbers, right? So a physician can try a new off-label drug. It looks like it's working. It's not a new therapy and actually can't be sort of approved to be tried as a therapy until we test it in enough patients under the right conditions to tell if it actually works. And the challenges here are every patient is different and the disorder changes over time. So if you do an N of 1 study, which is one patient being treated, we can get really exciting data. But then we have to come up with a controlled study, a clinical trial, where there's patients often that don't get the treatment and patients that do, although that's not always the design of the trial that we want to use. And then you ask, is there evidence with statistical analysis that the individual actually got better? Right? So that's the type of next steps that would happen downstream of a promising off-label treatment. The same process happens with these new therapies, but there's a big phase where you do safety instead of just, is it effective? Because if it's totally new, the FDA doesn't know if you should be putting it into people. So those are the types of approaches we take when we're looking to understand what therapies might work and then to test them. One thing I want to point out, going back to how you guys can be involved and how your efforts are really powering this, one of the biggest things we need to be able to test if a drug is effective in a clinical trial is data about what the disorder what the disorder looks like for patients. And by collecting the data on enough individuals, we know what to expect, even if there's some heterogeneity, and we have a better idea of how we're going to measure if there's a change. There's something called outcome measures that are really critical for clinical trials. It's basically you say, this is what I'm going to measure to see if it changes. And the better you know the disorder, the better you can sort of come up with those outcome measures, which usually you have to say ahead of time they're going to be. And then you can tell the FDA this worked or it didn't work, right? So the patient community, by giving us as much, helping us researchers out as much as possible, getting what the disorder looks like, what the experience of patients is, what their progression over time is, gives us that knowledge base to know how we're going to test if a drug works. And it's really, really essential to do it in a structured format so that we can actually know whether or not a drug works. If we don't measure folks beforehand and afterwards, if we don't use outcome measures that are sort of relevant to everybody with the disorder, and it's not done in the context of a clinical trial, it will be very hard to know if any drug actually works and be able to say, yeah, this is something we should be prescribing in general. So that's really important to be thinking about when we think about testing therapies, and really, a great way that this community is contributing already to the idea of how we're going to do therapies. So I'll just, sort of to wrap up, note that there are quite a few challenges as a rare disorder group trying to get therapies. They're multi-system disorders, as you guys all know much better than us researchers, and it makes sort of finding one drug may be difficult, but we do, in terms of opportunities, know the root cause, and so going after the WAC gene is an opportunity for us. We do have small populations, so we have to be coordinated and think about clinical trials and think about how we're going to collect data in order to be able to do the tests we need to do. We used to think of that biotech and pharma might not be interested in our disorders because it's a small population, right? How are they, unfortunately, going to make money making a drug for 200 patients? The great thing, which is it's great when that sort of bad real-world stuff gets in the way, is that the pharmaceutical industry and the insurers have realized that there is a business model that works. That basically, if you come up with a treatment that's effective, you save so much money over time that they will sponsor the development of the therapy, even sort of for a rare population. So we are in an environment, unlike 15 years ago, where the biopharmaceutical industry does look at disorders like DESSH and Rett syndrome, for example, and say, we will pay for it if you get a therapy. So that's great, and it continues hopefully to be that way. We think we can get support once there are other opportunities. I just wanted to close, and then we have a discussion. I hope I didn't go too long. How can you chip in? I know you guys, as caregivers and patients, there's a lot on your plate. And as a researcher, it's always amazing to come to these meetings and see that folks are taking their time and finding a way to come and be here and learn more. I hate to ask for more, but if you participate in research, if you're sharing your biospecimens, your health data to help with the registry and developing a natural history study, and sharing your priorities for what you really would want to be treated, that helps us get direction on where we go and gives us the sort of what we need to be able to make progress. Be an educated partner. It is all very complicated, but if you are sort of watching what's going on, participating in clinical trials when you see them coming through, when it's possible, realize it's challenging. That's, I learn from coming to these meetings and talking to patients and caregivers every time I come, and it's because you guys are engaging, so that's an enormous help. And then you guys are superheroes when it comes to advocacy and getting people's attention. And now more than ever, we need advocacy for science. So all the work I've done in DESSH, most everybody who's doing research were NIH funded, and the NIH is unfortunately looking at something either flat funding or 40% cuts. And if you speak up and you say, I have a child with a severe disorder, and NIH funding is funding us finding therapies, Congress people will listen. You are the folks that deserve to be heard, and so if you feel comfortable speaking up, it's that kind of funding that leads to treatments, and so I would encourage you to do that. Okay, I'll leave this up, and then I guess we're going to have a panel. I'm happy. Maybe we'll all sit down. We can start asking questions.
Yeah, no, thank you so much, Dr. Gable. We are going to invite, yes, please. We're going to invite up members of our medical advisory board and researchers at WashU who will be working specifically on DESSH research to join us here at the table. And we're going to talk a little bit, I need it really dumbed down for me, what we're going to glean from these animal models and basic research. And so I came up with a list of questions, and we're going to see how these folks can help us understand what they do and how we, as patients, can impact what their research finds. So, families often asked, where are we in research? How far is treatment? Much of the earliest work is done in research labs using models, both animal and cellular, to understand what's happening in the body. Today, you'll hear from 3 scientists working on DESSH using mouse and zebrafish models, as well as iPS cell lines made from patient samples. They'll explain how these tools work, what we've learned so far, and where we're headed next. We'll also leave time at the end for your questions. Before we get into specifics, I would love for each of you to briefly introduce yourselves. Could you share a little bit about your lab, the kind of models or tools you work with, and your main focus when it comes to DESSH?
Certainly. Hi, I'm Daniel Votes. I work at Michigan State University as an associate professor. I got pulled into DESSH, I guess, about 3 to 4 years ago, because we started working on a WAC mouse model. At the time, we didn't know much about it. We got interested in it because it overlaps with some of the other rare disease genes that we had been studying in our lab. I particularly focus on a mouse model. That's what I've been trained on. We do a lot of brain development, which means from conception through adulthood, we look at different stages of how a mouse basically forms its brain, how it behaves, and different cellular and molecular underpinnings of this. My big thing is I'm really interested in the biology of autism, and that's what attracted me to WAC in the first place. Some of the stuff that we have been working on is to develop 3 different models of WAC. The one that's most important for this group and our talks today is what's called a constitutive heterozygous model. What this means is that we got rid of 1 copy of the WAC gene in every cell in the body, which reflects about 95% of patients. And through this, we've been working with Dr. Kim in Korea, who's also generated a zebrafish model, to look at the various symptoms that might recapitulate in these models what humans are going through. To date, we have a lot of behaviors that are changed that we can potentially use, as Harrison mentioned, for therapies later. Sorry. So we've now established some learning behaviors, social behaviors that might be relevant for the autism in these models. We now have some cellular and molecular findings that we're following up on. We also have a set of genes that are regulated by WAC that are now potential genetic candidates that we can move forward later. And I know Harrison will go into more detail about potential roles in the nucleus that WAC might be playing. And with that, I will pass.
I guess this one's on. So I'm Kristen Kroll. I'm working in close partnership with Harrison on a number of rare disease modeling projects. And although we do use mouse models in our lab to study other IDDs, or neurodevelopmental disorders. The primary goal here is my work using patient-derived human stem cell models to make neurons that recapitulate the same deficits on the same genetic background as are present in your children. So what we do is we get blood draw, or we get a skin punch, a skin biopsy, from individuals with the WAC gene mutation, or DESSH, and we will send that to our reprogramming facility here at WashU, and they will make us an iPSC, or induced pluripotent stem cell model. And these models are really powerful as a complement to animal models because they recapitulate all the genetics that your patient or your child has, as well as the WAC gene, and that can have consequences for what we see. We can do a lot of things with these cells. As I think has been pointed out, they will never be an animal. They're never going to get up and walk out of the dish, but we can make them into neuron networks that recapitulate a lot of the altered neuronal imbalances of neuronal activity that might be contributing to the findings of the disorder in the brain. And we can also develop, because this is a developmental disorder, we can also look at how development of brain cells is altered in the dish. And if we can use that to figure out some easy assay that is drug screenable, that we can see corresponds with the condition, then we have the ability to use these models. They're very scalable, so we can use them for either of the modalities that Harrison just introduced, either for gene-targeted rescues to see, do we rescue normal function, do we rescue normal development or normal neuronal brain cell identity, or can we try repurposing drugs? So I think there's a lot of, I think we're going to get into this a little bit more, there's a lot of complementarity with making these cell models, and I would just recapitulate Harrison's desire that if you want this research to move forward, to support the NIH and contact your Congress people about this, because we need to have good pathways to be able to do this kind of work, and participate in the clinical and natural history studies, and be able to provide materials that we can use to make these models. I think there's a lot to be had using these models to study these neurodevelopmental disorders, and we would love to work with you on that. I'll turn it over to Harrison.
Great, thank you, Chris. So yeah, I get the pleasure of working with both investigators here. That's because, in addition, so I mentioned that I have a role doing rare disease research for neurodevelopmental disorders. I work with patient groups, and we try to understand the basic biology of the disorders and then think about therapies. I got into this because I actually study the way genes regulate other genes. So we mentioned WAC is in the nucleus of the cell. That's where the DNA is, and what we think one of WAC's major roles is to help turn on and off other genes inside the cell. That's what my lab does. So I had a very talented graduate student in the lab, Alyssa Bierstead in the back there. When she came to the lab, I said, another great scientist at WashU, Amanda Smith, had said, hey, we got these models, we could work on this, and this might be something you're interested in. And I said, well, we'll do some experiments to see if WAC works in the nucleus and regulates other genes. And if it does, then we're good people to study it. So we'll go ahead and do it. And Alyssa's results very strongly support that. So we're the right molecular biologists. So what my lab does my day job is to study how proteins inside the nucleus turn on other genes. And in neurodevelopmental disorders, often that's what's disrupted, and WAC is one such case. I work on several other disorders where the same type of thing's happening in a different way. And so we are very good at, hopefully, measuring the way these proteins function inside cells, turn on and off other genes. And the great thing is we can work in mouse models, and we can think about what's going on inside the cells that might be causing the phenotypes that Dr. Vogt is very nicely characterizing, sort of in terms of overall development of the brain and function. And we can also work with Dr. Kroll in terms of understanding, is the same thing going on in the human cells, and comparing those two things. So we're really doing the molecular biology of WAC, and then once we learn that, we get to sort of come up with ideas for therapies and try things like gene therapy. So that's the type of work my lab does. It's really molecular biology of the disorder, and we're hoping to interface with everybody and help facilitate the research.
Thank Thank you. I remember that time when Amanda Smith, who's also on our medical advisory team, started here and just has left. But when she developed these mouse models and then said she was leaving, I said, what is going to happen now? And there was a period of time where Dr. Gable was like, I don't know if I'm the guy, and let me look through it. And he's the guy. So we're really glad, and we're so happy that we have Alyssa by his side, who spoke with us last year, too. It was wonderful. So I want to dumb it down even more. Let's start with the very, very basics. We've spoken a little bit to it, but if you could simplify this in the simplest terms. And Dr. Vogt, I know you're going to also be speaking a little bit on behalf of Dr. Kim from Korea, who has zebrafish models. Why do we use animals or cells instead of studying people, instead of just studying people? What can we glean from them?
Test. Okay. So the main thing is there's timing and there's ethics. Timing, a lot of the animal models, they can generate progeny very fast. In a mouse, it's 19 days from conception to birth. Humans, even if you could get a big cohort together, you couldn't look at the development of a human over so long. This is where the natural history studies are really important for the human side. That will be very, very valuable as we move forward. But in the mouse, in the zebrafish, there's very rapid development. We can actually scale it up. Like Dr. Cole said, we can actually scale up our colonies and look at multiple animals. And again, the more animals we can study, the more accurate we're going to be in the long term. Does that answer?
Yeah, that was wonderful.
Same question for me?
Well, no, because you deal with patient-derived cells. So tell us what the importance of using stem cells is.
Yeah,
the difference.
So as I mentioned briefly earlier, these are nicely complementary models. They are cells in a dish. They are stem cell-like cells when we derive them from your blood or from your skin, and they can make all the cell types in the body. In our case, we want to make them into neurons that would be populations that are likely to be disrupted in the patient, and then use those. We can do a few assays in the dish that are very helpful for screening for drugs. We can look for changes in the way the neurons develop. We can look for changes in the way that they talk to one another and touch one another and communicate. So we can actually look at imbalances in the function of the neuron networks in the dish. And unlike the neurons that would be in your brain, we can actually manipulate those. We can drug them. So you're not going to your clinician and saying, okay, let's treat some symptoms like anxiety or autism where we have no molecular leads. We can also, we also focus, as Harrison does, on the molecular biology of these kinds of disorders, not DESSH particularly, but looking at genes that act like this to turn on other genes. So we have a lot of data sets that we can generate on that front to look at, well, what are the targets? Which pathways are disrupted? And that leads us to the kinds of treatments that Harrison was talking about, to drug repurposing. And once we have a sense of what drugs we should be trying and or can screen for that, these models can make human neurons that would resemble those in a child's brain, for example, in a relatively short period of time. You figure a kid takes 3-4 years to get there. We can make the cells look somewhat like that in about 20-30 days and recapitulate a lot of the functional abnormalities that we think are contributing to the disorder. Is that?
Yes, thank you. Dr. Gable, I wondered if you could explain, once we have patient-derived cells in a dish, why we still need, or do we still need, animal models?
Right, so absolutely, particularly for a developmental disorder. What's affected in individuals with DESSH is organ systems, behavior, all the things that happen in a living, breathing person. The cells are amazing for allowing us to study the mechanism and sort of boil things down in a reductionist way, and in the context of human genetics, which is, the mouse genetics is not identical, so that's really, really important. But then if you want to understand, for example, if a gene therapy will help, you need to do it in a context where you have a functioning brain to see, there's certain ways in which if we put the gene back, but the brain hasn't developed quite right, the gene therapy might not be the optimal strategy. A mouse can help tell us if there's a window when we need to put the gene back. And sort of certain circuits may be more amenable to correction than others. So having those intact circuits, having a whole organism is a really important complement to the wonderful sort of ground truth that we can get from human cells, and we can compare them, directly and work with them. So they bounce back and forth in this really synergistic way. So both absolutely essential, and the great news is, some disorders the mouse can't replicate certain aspects of the disorder. In DESSH, it seems like the mouse is going to be a very good model, and the zebrafish too. So we're very lucky, and they'll complement each other going forward.
So this will be for anyone, and we've touched a bit on it, but again, in a dumbed down way, if I could put it that way. How do models like mice or cells actually lead us to a treatment? How does it, what would delivery of something like a treatment be for a patient? How do we receive this from your labs, and what's that do? How?
I could jump in, unless you guys. So I guess there's sort of two phases. There's one, the development of the treatment that could work. And the great thing is we have the biopharmaceutical industry doing that. So they're creating, for example, gene therapy. There's all these companies creating gene therapies, and all we have to do, we need to entice them to the idea that DESSH is the right place to try their therapy, because they want to successfully make therapies. So if we do the right experiments to show that it's a good idea to try to do this, a biotech or a pharmaceutical company then we can start to make contact with them, and they can bring their technology in, and they will then do the testing in animal models and in cells. And then it will move forward really with the full weight of a biopharmaceutical company. Our job is to what's called de-risk DESSH as a target, right? We could even do the first version of gene therapy in our lab, and for example, some folks at WashU are working on antisense oligonucleotides that could be used for DESSH. This is a type of gene therapy, or gene-targeted therapy. If we can do enough experiments to say, it looks like it might work, a company that makes those therapies will say, ooh, we'll come in and do it. So it'll be a handoff from our research to a company that has the resources and the ability to develop it. Now, it will never be that, hopefully, and the evidence supports this, the good news is they'll be in direct contact with the DESSH Foundation throughout the process, because we have all the knowledge, we are the patients, we are the advocates, and so they want to partner with these groups. It's not like it disappears and then the drug comes out or not, but it would become a partnership with the biopharmaceutical industry. Not that we can't do proof of principle experiments, but to bring it all the way, it's usually a biopharma that's going to do it. And there's a model for this, and it's becoming more and more popular amongst the industry to do this because of successes in Rett syndrome and other disorders like SMA. So one thing to be cheering for is that those continue to have successes, because the industry wants to see those successes to de-risk their approach to then bring it in. But that's the type of way it will develop.
Yeah, I've been learning a lot about just how the traditional methods of getting from a diagnosis to a treatment for something, a general issue is it doesn't work for rare disease. Like we're too unique, we're too small, and so that's sort of why patient advocacy groups have to really come together and be the leaders of the research and the impetus behind all the great work that you guys can do for us.
Sorry, I just wanted to add one quick thing. Yeah, that's exactly that sort of de-risking. Our organization is the one that's interested in doing that, and until we do that, it's hard to get interest once we do it. So that's the big challenge for a rare disease organization, and why it's different. I guess the other thing I forgot to mention, of course, is drug repurposing is a little different, right? We may just be able to sort of start doing clinical trials with folks, and it's something we need to talk about. That's sort of not a totally new therapy, but a repurposing approach. So I don't want to leave that out.
Yeah, we'll deep dive into that following this presentation. So I wonder how we're doing on time, because I do wanted to ask what you guys find maybe in each of your individual specialties or areas, what you find your biggest challenges are in this type of research.
Sure, yeah, stem cell lines are a really essential, and stem cell-derived neurons are a really essential tool for repurposing drugs, for testing antisense oligos, for testing any of the either gene-targeted or drug-targeted therapies. And as Harrison has suggested, we work very closely across the animal model and the cell model domains, and we want to be able to try, the analogous gene-targeted therapy or drug therapy in both systems, because that gives us higher confidence. But one of the challenges of this, as you can imagine, is that there's a lot of complexity and there's a lot of money involved. And so it's very expensive, it's very technically demanding to make these cells. Every mutation you guys probably have a range of mutations in the WAC gene, and every mutation is going to behave a little differently, so we need to make enough models that we know that we've captured the disorder in a dish, and we're not testing a therapy that's only going to work for one patient or patients that have one mutation. So there's a lot of work involved, but I think that what we've learned over the last few years with all of these rare disorder foundations like your own is that we can get around the issue of not very many patients maybe having the disorder relative to other conditions like heart disease or stroke, and we can get biopharma industries interested in this if you guys come to the table and say, hey, we're gonna try this, we're gonna advocate for it, we're gonna have the models in hand, they will be interested in repurposing their own drugs or testing therapies if we show that it can work.
Just real quick too, I think when we started, making these mouse models, one of the things, catchphrases that Harrison mentioned was outcome measures. And one of the things that the animal models and the human cells are helping us figure out now are actual changes due to loss of the WAC protein that we can measure very rapidly and scale up on. With those, both genetic rescue and even repurposing of drugs is now possible in the dish. And then with some of the animal models like zebrafish and mice, we can go in and see if further that behaviors are also rescued. And that gives us more ammo, I guess, going forward, trying to convince the pharmaceutical companies as well.
So I want to thank you guys all for sharing all your wealth of knowledge with us, and I hope you'll stay for a few minutes. I'd like to open it up to questions. Anyone that would like to speak, we would love to. We've got Kim Turner here for us, everyone.
Oh, I don't have a question.
Dr. Kroll, I was just wondering if you have any sort of reports based on the skin cell research that you have done so far.
Do you mean success stories on with other developmental disorders? Or
have you used any of the DESSH skin cells at all?
I have not worked directly with the DESSH cells. Harrison can probably fill you in on where we're at in terms of getting a really good bank of DESSH cells. What we want to have for all of these models is deeply phenotyped patients, which Marwan has, and we want to make the cells from those individuals, and we want to represent a range of mutations. And I think we're actively working as a community to try to figure that piece out. And it obviously takes a lot. There are human subjects considerations if we're going to make these lines, and we want to be able to report this is what the patient had, but we don't want to reveal the identity of that patient. We want to be able to publish on it. We want to be able to have a bank of cell lines that will really be a useful tool for the field to figure out which therapies are going to work. And that obviously involves a lot of lawyers, a lot of time.
Okay.
Harrison could probably fill you in on where we're at on the logistics of making that happen. But we've done it for other conditions, so I think we can do it effectively for DESSH as well.
Okay, that's exciting to find out. Thanks.
Any other questions?
So just a few questions, I would say. One, does it help if you are able to get, while the baby is born, so some of us might have got their stem cells stored at that point of time. So does it help if you get samples of that, or, does it help in the research better as compared to drawing it fresh from the patients now?
I've been debating that. We had our son's umbilical cord stem cells banked as well, and we keep paying New England Cord Blood Bank for storing those samples. And I'm still. I feel like the science has almost gotten to the point where we're not typically going to reach back to those samples. because the stem cell biology, back when we banked those, which was in the early 2000s,
Right.
the stem cell biology was not what it is today.
Right.
So today it's quite, there's quite a lot that we know at the level of how the genome changes when these cells become neurons in the dish, how it compares to the genome changes in the mouse and the epigenome, that basically how gene expression changes are happening. And so we feel like the stem cell models, what's called induced pluripotent stem cell models that we can make from blood or from skin of an affected patient, those are a pretty faithful model. And I don't know that there's a lot of extra bang for the buck to be had by,
Right.
I would love that to be the case too, because we've spent all these years paying for New England Colloid Blood Bank to store our samples. I don't know if you have a sense of whether there's any unique, things that those kind of stem cells would get you at this point.
So I agree with you. With the progress that has been made, there's specific utility.
Right. And with the induced pluripotent stem cell models, or knocking a variant into a normal control cell line model, we can control everything, basically. Humans, as you know, are not inbred, so humans mate with whoever they want to. So this represents a challenge with doing this kind of work, because we would like to isolate all the other variables, which all your genetic backgrounds are going to be different. And we just want to look at what that mutation in the WAC gene is doing. And so we want to control all of that. And we can do that by either building a large panel of different iPSC lines from different patients, or by also using control cells and putting in a particular variant that one of the kids might have.
Just one more question for you, sir. So we talked about, first it's about the team developing this in the labs here, and then pushing a pharmaceutical company to come forward and take this up, right? So if you were to draw a timeline, kind of a progress line, I wouldn't say a timeline, but like a progress line, where exactly are we in that journey today? And the other thing that came up was that, it's a costly journey, right? It requires a lot of funds. And what typically would be a funding requirement for this journey? I know it's a difficult question, but what typically would be a funding requirement for this journey? And as a group here, apart from funding, whether it's contacting some pharmaceutical company, whether it's contacting some research laboratory, what is it that we can do to help, just rather than advocating about it to various people, but a kind of a targeted approach that, yes, if there are people who have links in the pharmaceutical industry, if we can get A, B, C, D, it'll be helpful, and similar things to the other points.
Sure. Wanted to close with one idea about the biospecimens. The cord blood aspect is sort of the field has moved beyond it, but biospecimens in general and donating them is really very important, and there's a place for making this very specific change so that we control everything else and then just look at the variant, but also, lots of cell lines from different individuals, and in the long run, that will be a great resource. So cord blood specifically maybe is less relevant, but biospecimens such as skin punches or blood is really, really valuable to, as a community, have. And so those types of efforts should continue. Just wanted to sort of double down on that. In terms of where we are, so my roadmap wasn't sort of a linear roadmap, right? It's got, it's got columns, and that is sort of the way it progresses, right? You can make a lot, some disorders have a lot of understanding of what the disorder looks like, but don't have animal models. The linear roadmap is sort of gene, then cellular models and understanding of molecular mechanisms, then therapeutic candidates that come in at some point, and then development through biopharmaceutical industry. We're establishing our models and showing that they have utility. So I guess we're at that second stage in a big way, but we'll hear a little bit more about what their, sort of immediate therapies could be. So we might accelerate in certain ways. I'd say that's about where we are. In terms of how much resources we need for that, that's very hard to predict. Things are very nonlinear in science. You can hit your head against a brick wall for years, and then make some insight, and then you go fast. I think ideally we'd want multiple full-scale R01, if you've heard of an R01 grant, research projects funded by the NIH. And that's really where you're going to get the money, because these are $500,000 a year, multiple investigators, and we'd want to try to get to the point, and we're trying hard to get to the point where we each have one of those. So that would be, $1.5 million in direct costs, actually, more like $750,000 a year per lab, and we would do that for 5-year chunks. So that's the type of funding we want to be pouring into DESSH, and the great thing is the NIH is set up that, you know, we can get there. NIH right now, funding levels are really, really low, so it's the biggest challenge we've had in years. It's very daunting as a researcher, but we're committed to doing that. What can the foundation do? The foundation, in terms of, you know, advocacy and participation in the clinical research, is first and foremost what you can do, and you know, in terms of being a patient or a caregiver, is unique, right? So that's what we want you to focus on most. But in terms of what you can do in terms of funding research, we want to think about sort of pivotal experiments that would facilitate getting more of that NIH money. Having a mouse model where we can show that it really replicates key aspects of the genetics, and then it looks like a good mouse model. Proof of principle that a gene-targeted therapy could work. So a small set of pilot, you know, a pilot project that says we're going to try ASOs and look, it could work. Or gene therapy, you know, in this not toy but smaller experiment looks like it could work. Then we can go and there's a multiplier effect that comes from that. And those are the key experiments that I think that a foundation like ours wants to focus on. Because the large scale stuff, you really just need government level funding and then a biopharmaceutical company come in. So that's what those key experiments, and if we think about funding research and the iPS cell development is exactly that. If you have iPS models, you're in a different place than if you don't. And if you can distribute them to researchers, then people can get preliminary data and then they can apply for grants. And that's, I think, why Caitlin is focused on that and why we're hoping to get it, you know, ramping up. Chris.
Yeah, and I could just add an example that I've had with interactions with other foundations where, you know, in order to get a company interested in developing an antisense oligotherapy, they typically have criteria, you know, before they'll adopt putting this out. So they want to have a good stem cell neuron model, an iPSC model that they know has outputs that they can look at. They want to know that the mechanism of the gene is understood, that this is loss of function. So we know what we're trying to do. We're trying to add back the proper dose, whereas if the gene has a toxic extra function, that's, you know, or if you're worried about the dose, overshooting the dose, you know, that's a problem. They typically want to know that we've got these preclinical models. It's not NIH level funding to just begin to make stem cell models. So that's why I would suggest that if, you know, we can get blood draws done and we can pick our patient population, what mutations do we want to look at? You know, our facility will make us a stem cell model or a stem cell model pair for on the order of $10,000 to $20,000. So that's usually not beyond the, you know, the ability of a private foundation to kind of come up with some funds to just really spur, you know, development of these other approaches that are more costly.
So, and this is where we are. I can speak just quickly. We as a foundation have been really speaking with our medical advisors, and this is the exact advice that we've been given from all of them, which is we can fund the little things that lead to the big things. And so that's just what we've done. We've started with this clinic that has led to Marwan receiving a large grant for a natural history study. And we're now working on this iPS cell line agreements to get 2 stem cell lines put in place so that we can study these. And we've organized with YCell, a separate institution, to be able to, once these are actually created here and before they're studied, be sent out so that it's available for other researchers to then access and do their own studies on our same stem cell line. So we're developing the tools that then we can pass off to these guys to then, you know, get over that next hurdle that we're reaching for. So with that, I want to thank our panel today and really appreciate you guys for being here and for sharing all of your knowledge with us. So we have one more presentation to go, and I think it's within our same Pathways to Treatment part 2 of this. And we really just did an overview with Harrison, and then we did a deep dive into animal models and basic research. And now we're going to do a deep dive into N-of-1 studies and drug repurposing. And we have a really, really awesome basically, what's the word? example of what these women from the Mayo Clinic have been able to achieve with an N of 1 study through a DeSanto-Shinawi syndrome patient. They have traveled here from the Mayo Clinic, and they are here to give us their rundown of this deep dive into N of 1 studies and drug repurposing. Before I kick it off to them, Kim Turner has asked for the mic. Listen up.
Hi, guys. Okay, I know that little ones are probably slowly starting to melt down, but we are almost done. I have been holding your schedules hostage for a very good reason. So once this is all done, I will have schedules for all of you, but for all of the new parents, I do need you to hang out for a little bit. For anybody who has testing at the other site, we will get you taken care of and get you walked over there, so don't worry about time and any of that, okay? All right, here you guys go.
Hello, everyone. Thank you so much for having us today. We're very excited to be here. My name is Whitney Thompson. I'm currently, I just finished up my clinical genetics training at Mayo Clinic, and I'm also a neonatology fellow as well. This is my colleague.
Hi, I'm Dr. Laura Lambert, also at Mayo Clinic Rochester. I'm an assistant professor there in physiology and biomedical engineering.
And financial disclosures, I serve on the clinical advisory board for Inflection Medicine and engaged in a know-how agreement with the company. So I want to start out with the problem. What is it that Dr. Lambert and I sought out to solve with our Baby Force program? So as many of you might be aware, we are now doing ultra-rapid genome sequencing in our NICUs every day. We are getting ultra-rare diagnoses on a daily basis. And unfortunately, our ability to diagnose these ultra-rare conditions has far outpaced our ability to treat them. And as both a clinical geneticist and a neonatology fellow, one of the hardest parts of the job is saying, yes, we found a diagnosis, but no, there's absolutely nothing we can do about it. Certainly getting the diagnosis is the first step towards a treatment, but we wanted to work towards a scalable approach to addressing this problem. And so we co-created a program called Baby Force.
So Baby Force blends the clinical and research sides beautifully for this type of approach. And what we've done here is set up a pathway for any patient that comes through the NICU with a molecular diagnosis, where we can look at the mechanism and identify an assay type, make a model of that patient, and then assess the drugability. But what really differentiates us from other programs you may have heard about or completely computer-based research is that we take an extra step of testing any drug hits in the patient's own cells before reporting back any hits to the clinical team.
So we're going to walk through this process with our patient Jory. And many of you may be familiar with Jory from the recent news story. I first met Jory in our NICU. She was born with multiple congenital anomalies and low tone and poor feeding. And because of those issues, we sent ultra-rapid whole genome sequencing for Jory. And sharing some photos, these were shared not only with parents' permission, but encouragement, because just look how cute she is. And so whole genome sequencing came back with a heterozygous de novo deletion of chromosome 10, consistent with a diagnosis of DeSanto-Shinawi syndrome. And I won't go through the condition, since I know we're all familiar here. But importantly, as many of you or all of you are aware, no current cures exist for this condition. And so Jory became the second patient enrolled in our Baby Force program. And so the first step before we use our AI tool for drug repurposing is to make sure that we understand the mechanism of disease. And so in this case, haploinsufficiency of WAC is considered the main molecular mechanism. And we do know that WAC is expressed both in fetal stages all the way through into a specific adult brain regions. And so our hypothesis was that upregulating the remaining copy of WAC could potentially restore functional levels, and that could be a potential therapeutic option. And so we've identified the mechanism, and then we need to identify our model system. How are we going to test this in the lab before testing this in our patient? And so we looked at expression data and found that WAC is highly expressed in the skin. And so we were able to get a non-invasive skin biopsy for Jory, grow fibroblasts, and those were then used for multiple assays to test the drug. But now I'll turn it over to Dr. Lambert to talk about identification of the drug.
So the tool we like to use, and the The subject of repurposing was touched on earlier, so I won't belabor that too much. But the tool we like to use for that purpose is called MediCanron. And it's an AI reasoning agent that connects genes and drugs using a rational algorithm. So this is based on the mechanism that we identified earlier of haploinsufficiency in this particular case, where we're just thinking rationally here. So we're underactive for the amount of WAC that we'd like to have in the body, so we want to activate. So that's the query that we run here, which is what activates WAC? What drugs are out there that are already FDA approved that are predicted to upregulate WAC levels? And so this tool has genes and drugs organized into distinct nodes that new relationships can be inferred from. So if we understand that blue increases red and red decreases green, that logical reasoning step that blue may decrease green is how this tool works. And so we end up with this whole kind of network of knowledge and new inferences. So that's what we used here to get a list of drug candidates that we then wanted to screen.
And so at that point, the output from this AI tool is a list of FDA-approved drugs or compounds that could potentially, in theory, upregulate WAC. And so that list can be exhaustive. In this case, we had hundreds. And so with the help of our NICU pharmacists and our clinical team, sorted through that list and prioritized those drugs to basically ask the question, what would we be comfortable actually treating our patient with? What's available? What has some safety data? And in this case, for DeSanto-Shinawi syndrome, we needed something that could penetrate the blood-brain barrier because we knew we were targeting a neurodevelopmental phenotype long-term. And so we ultimately prioritized one specific drug that had safety data, that is available, an appropriate route of administration for a baby, and something that we knew to cross the blood-brain barrier. And so we moved forward with that specific drug. And so at this point, we have our model system. We have Jory's fibroblast growing in the lab. We've identified the drug, and now it's time to test that drug.
So the first bit of data that we'll show here is quantitative immunofluorescence. And what we're looking for here is an increase in the green signal that you're seeing. And not just the green signal, but the location and intensity of that green signal. And so what we're showing here is our control cells, or wild type, Jory's untreated WAC expression levels, and then the response of her cells to drug treatment in a dose-dependent manner here, restoring them to levels in line with the wild-type controls. The next experiment that we did is droplet digital PCR. So figure 1 was looking at protein levels. This is RNA-based. So we're seeing, looking at 2 different levels here. Again, on the left is control, Jory's untreated cells, and then Jory's cells in response to drug treatment here. And some housekeeping controls here, just showing this isn't a global upregulation. It's not, a general cell stress from what we can tell. And then the final experiment that we'll show here is flow cytometry. This is, again, looking at WAC protein. This is control cells, vehicle treated, and drug treated, and then Jory cells before and after treatment. And what we're looking for here is an increase in cells that fall within this polygon.
So taking all of that information together, so initially with Jory's case, given that she has a large deletion with multiple genes involved, there are some unique challenges to this approach in targeting one specific gene, but in this case, we knew that her phenotype overlapped with deletion of WAC specifically, and so that became the target and this strategy. And so our conclusions based on the initial experiments is that this repurposed drug that we identified through AI upregulates WAC expression in vitro in our patient's own cells relative to wild-type controls. We also know this drug is considered safe for use in children and is known to have significant CNS penetration. And so taking all of that together, we felt like we were at the point where we were ready to bring this treatment back to our patient. And so this was really a first of its kind at Mayo, and there was really no precedent for what exactly this should look like. And so we worked closely with our clinical ethics department, our biomedical ethics research department, our clinical trials folks, our IRB, the legal department, to figure out what is the best way to make sure that we're doing this, the best way for this patient, and to make sure we're going to understand if this is working or not, or if there are any side effects, how are we going to capture that? And so ultimately what we decided to do is pursue kind of a hybrid research clinical approach here. So since this is already an FDA-approved drug, we had permission to go ahead and just prescribe this off-label for the patient. That happens every day in pediatrics, especially in the NICU, given the limited data on drugs that we have for our patients. And then at the same time, follow the patient under a research IRB so that we can continue to collect data to find out if this is working for her. We knew it worked in her cells in the lab, but at this point we didn't know how that was going to translate to our patient. And so our approach here is that we convened really an expert clinician and research team panel involving multiple of Jory's subspecialists that were already following her. We created a comprehensive plan to get a baseline phenotype assessment before we started treatment, and then serial testing as we went, and then kind of what some of our endpoints would be. And then at the same time, when we do those phenotype assessments, we're also taking a blood sample, and with that blood sample measuring WAC expression in her blood as we go, and then also measuring the drug levels in her blood. And so with all of that, we followed her very closely over time. She started treatment in April, and this was an exciting day for everyone. This was Jory's first day of treatment. We got to be there at the clinic visit. And we have just been blown away by her progress. And so the first things that we heard, so these are videos pre-treatment, some in like the months before treatment her mom sent of her mobility. So working on crawling.
Here we go, here's the blocks, there they are. We're gonna get them.
And then fully supported, making some efforts at steps, but not able to bear weight at all pre-treatment. And then we heard from her parents just in those couple weeks after treatment that she was starting to take her first real steps. She was starting to talk.
What a big girl!
And we were just obviously blown away and very excited. And the way her parents described it to us is that it's like the lights have turned on. And they felt like they were seeing very clear differences even just in that first month of treatment. And this was confirmed by multiple of her therapists who said that her developmental trajectory had changed. She was making progress at a much faster rate than they would have expected based on her previous trajectory. And so we were seeing that from a development standpoint. Some other evidence that we were seeing is that, so one issue for Jory is that her airway tone is quite poor. And so this is a pre-treatment. She did have an airway evaluation immediately pre-treatment, but the videos didn't end up being good enough to be able to show here. So this is an earlier one, but speaking with her ENT physician, he said he was seeing the same thing that we're seeing in this video, but this is when she was younger. And for those of you who are not experts in the airway, like myself, I was, basically what you're looking at here is concentric collapse of the oropharynx, and so hypotonia of the airway. And within 3 months of treatment, that had significantly improved. And so just another way we're seeing some effect of this drug, and that's, Jory had trouble with significant noisiness of her breathing, some sleep issues, and that has started to improve a bit since starting treatment. So that has been very exciting, and another measure that's telling us that something is working.
So the final step that we do as follow-up here is looking at her peripheral circulating WAC levels. So we're able to do that by simply getting a blood draw from her each time she comes to visit the clinic, and it comes over to the lab where we're tracking that. And so this is 1 month post-treatment. These 4 on the left here are untreated. These are her WAC levels in her blood. And the 4 on the right are 1 month post-treatment. So you can see that we're detecting an upregulation in her blood. And then this is holding true, again, at 2 months post-treatment as well, where this is untreated, 4 weeks post-treatment, and then 8 weeks post-treatment. We can see that this difference is maintaining.
So taking both, the laboratory data with the WAC expression levels combined with her clinical improvement thus far, we feel that this drug is helping her. And we will have some more objective data at the 6-month mark, which is coming up in October. We'll have our kind of full post-treatment developmental assessment at that point, and so we'll look forward to seeing what those numbers are. But everything we've seen so far is supporting that that this drug has been helpful for Jory. And so I imagine many of you in the audience are wondering, is this potentially an option for my child? And that is something we are very excited about, and we are working very hard to figure out next steps there. So we have applied for funding for a potential trial. We are working through all of the layers at Mayo that we need to go through in order to stand that up. We don't know at this point the exact timeline or what that's going to look like, but just know we are committed to making that happen as quickly as possible, but we want to make sure we're doing it in the right way so that we can get meaningful data as well, so that if this treatment does work for other patients with DESSH, we can capture that and then it can become an approved treatment. And so just know we are very committed to working on that. We don't have the exact timeline or answers today, but as soon as we do, we will certainly communicate that with all of you. And just many people to thank who have helped immensely with this Baby Force program. Certainly our NICU, the Functional Omics Resource, our Center for Individualized Medicine, Department of Clinical Genomics, Mayo Clinic Children's, and most importantly, patients and families.
Thank you.
Thank you so very much. I'm sure we have some questions. Are you guys up for a couple of questions? Melissa?
Do you think the effects are going to be not sustained, but more applicable in younger children that are still in some of those earlier developmental stages versus maybe some of our patients that are in in puberty and adults?
I think potentially, certainly those key developmental windows, I would suspect there might be a larger effect, but I'm not, I think there's still a good chance that there would be effect at later ages as well, since we know that WAC expression is maintained throughout adulthood as well. So I would be hopeful, but I don't know that for sure.
Will you try to will you put those into your clinical trials as well, or if you're granted, if you go, or are you going to start at certain ages, or are you going to try to include a variance of age?
So at this point, we don't have the exact design, and it's going to, the inclusion-exclusion criteria will depend on what that ultimate design of the trial is going to be, but our hope is that we could make this broadly available.
Mine is more of a neuropharmacology standpoint. When you look at the drug Klonopin, it's a benzodiazepine. It has a high addiction profile, which means over time, of course, as kids grow and things like this, it's like the opposite of kryptonite for Superman. It's like, do you see possibilities of efficiency or efficacy, burnout, or things like that? I mean, are these things that you thought of? Because I know with like ADHD, I don't know the studies per se, but with stimulants, neurostimulants, it sometimes wears off.
Absolutely. No, I think that's something that we've certainly thought about. That is a concern. We don't know the answer to that exactly, but we're trying to capture as much data as we can so that we can answer that question as we go by getting continued WAC expression levels, drug levels at the same time. Fortunately, we didn't have, there was no way to translate dosing in vitro to the dose that we were going to give our patient, and so we started at an extremely low dose, just given that there are potential side effects with this drug, and there's no precedent for doing this, and so we started at a very, very low dose, lower than is typically used for its actual indications. And so we have room to go up if we need to. And so, we're hopeful that it will continue to be effective. We can't say that for sure, but we're collecting that data to make sure that we can learn from this, while also keeping the patient safe and using as low of a dose as possible.
And I'll add to that when we identified this drug as our primary hit, we did have those concerns in mind. So we also carried out a high throughput screen in Jory cells using a compound library specifically tailored to pediatrics of all FDA approved drugs, and we have a few other hits in hand as well in case this one doesn't turn out to be like long-term use.
So that's to say, we're not done just because we found one that might potentially work. There are others that we have, and we're thinking through, how to potentially introduce those. We at least want a full 6 months of assessment for Jory before we think about doing anything differently. And we're coming up on that, and we're excited to be able to analyze that data at 6 months, and then we'll go from there. But we are looking into other potential drugs as well, and we have some promising options.
Hi. Thanks for a great talk. I wanted to ask one question or sort of get you to comment so that folks here hear about the importance of knowing that about the clinical trial structure and the idea that could you just explain how if someone's already on the drug, they can't necessarily participate in the clinical trial? I think that's a really important thing for people to hear. If you're gonna, we're really excited about doing a clinical trial, but we might get in the way of that if folks end up on the drug. So if you could comment to that so that everyone understands that, I think that would be helpful.
Absolutely. So we do anticipate that exclusion criteria for the trial would be if you're already exposed to that drug, because it would get in the way of being able to analyze that data and having a true pre and post. And so we know there is a lot of excitement around the drug and the potential benefit for your children. We do want to do this in a way that we can make sure that we're following closely, that patients are treated safely, and that we're getting meaningful data. And so that's why we're working as quickly as possible. But yes, that is a great point. If your child is already exposed to the drug, that likely would be an exclusion criteria from any potential trial.
Marco Torin, language interpretation. My question for you is, how could foreign patients? Oh wait, hold on. My first question is, Jory, she's only has lost the gene WAC. Has it only been that, or has there been other genes that are missing as well?
She has a deletion encompassing 27 genes, only 3 of which have an established human disease correlation. But her phenotype most significantly overlaps with DeSanto-Shinawi syndrome from loss of WAC.
So we can't say with certainty that the other genes are not contributing, but certainly her phenotype does correlate with WAC specifically, and targeting that gene does seem to be improving her ongoing neurodevelopmental phenotype.
Okay, thank you so much. So my second question is would there be any samples from kids to be able to evaluate this module of investigation? Like, would you be taking other samples?
Yes, we've been having those conversations. We're particularly interested in getting samples that have a frame shift or missense variants versus Jory cells, which have a clean deletion, because we want to understand if upregulation would also be beneficial for those allele types.
All right, and I have a last question. How would patients from other countries, would they be able to have access to this treatment? Foreigners?
Our hope is that whatever the trial looks like, that it will be broadly available, not just in the US, but in other countries. I don't know exactly what that looks like right now, but that is definitely our hope and our goal.
One of the questions online is, have you seen any side effects of the medication?
Not really. I think because we're using such a low dose, and we're following very cautiously, but it doesn't seem that we've had any significant side effects so far. And Jory is followed by various subspecialists frequently, and so I do think we would see those if they were there.
And then we have another patient who says they actually do receive care at the Mayo Rochester, and they are wondering if I can give them your contact information or vice versa, so they could, since they're right there.
Of course.
So we have, since Jory's story came out, we've worked to develop a plan for how patients can come and be seen at Mayo, and then potentially enroll in in the Baby Force program for other conditions. For DeSanto-Shinawi, since we already have this drug hit, our goal now is a clinical trial, so it will look different.
I may have missed this. Just now living in the world of clinical trials, people like start emailing and asking me, is it 1 month, 3 years off, 6 months? What is the estimated time?
On the scale of months, I would say optimistically about 6 months until, do you think that's reasonable based on the conversations?
I think that's reasonable, but we can't say that with certainty, and we do feel a sense of urgency as well. I want to make sure that you're aware we also feel that, and we just want to make sure we do it the right way as well.
Just one last question for me. What about duplication genes to the clinical trial work with genes that duplicate as far as I can understand the results for granddaughter, duplicate genes versus missing genes?
We would have to take a closer look, but I believe if she has a duplication, we wouldn't want to pursue this avenue for her. We would need to identify a downregulator.
So the initial query with the AI program puts in the gene of interest, and then do you want to upregulate it or downregulate that gene? And so in this case, we were looking for upregulators. Could go through the process and look for downregulators, but I would suspect that this drug would have potentially the opposite effect that we would want in the case of a duplication.
Last question.
Just to be clear, you said post-treatment a couple times, but just isn't ongoing treatment right now.
Yes, yeah, just post-initiation of treatment.
Okay, one more.
I'm so sorry, we can't hear you. Oh, yes.
Yes, yeah, that's what we're, at least in the early stages of thinking that this could look like, is so that we don't, I know it would be a burden for all patients to travel to Rochester, Minnesota, and so our hope is that we can do this kind of in a more patient-friendly way, and with local physicians prescribing. There are some challenges with that, and so that's what we're working through right now, but that's the goal.
So I want to, you have one more question?
You said last question. Okay. I think I'm inferring a question that I've heard circulating, and that's I think if it's 6 months until, and I know we don't know and you can't say, but if you say in 6 months there could be a clinical trial, I think people generally speaking would say, we'd love to participate in clinical trial. I don't think there's many people that wouldn't say that. But I think without knowing what that timeline looks like and having that drug just out there where everyone knows, I guess I'm curious to know what, well, I'm going to anticipate the answer is you'll help many, many people if you participate in the clinical trial, while you might only help your child or the patient that you're caring for. But are there any other things to consider that would maybe give pause to a family that's like, forget this, I know what the drug is, I can get this right now? I'm not sure if you can answer that as directly as I've asked it, but.
Yeah, our primary concern is something I touched on earlier, which is, from what we understand from conversations with Dr. Shinawi, the majority of patients don't have a deletion like Jory has, and we don't know what the consequences are yet of upregulating a different type of allele. So that's why we want to have these conversations and do more testing and understand, what the risks are of using this drug in that case.
And while this drug does have, long-term safety data out there, it's not a completely benign drug, as we've touched upon, and so there are potential side effects. And so, if we're not certain that it's going to work for other types of variants and balanced with the potential for side effects, I think doing this in a kind of a scientifically rigorous manner and following many patients to make sure that this is safe and effective is the best way to do it. But we do feel that same sense of urgency. If we want your children to have a treatment, and so we're balancing those things as best we can.
If anybody has questions about how you have more questions about that, just hold on to them.
Can I just respond to your comment? As a dad who just got a diagnosis 3 months ago, my heart was I want to do exactly what you were saying, get my kid onto the drug as quickly as possible because I'd seen what happened to Jory. And I wanted to do that straight away. Then I started thinking in my head and actually realised this drug is for life, if it's going to work. Also, we've got a different gene to Jory. How much do you give? Do you have to monitor it, change the levels? Do you need to change drugs? So I was exactly like you, and I wanted to start it. But actually, it's my wife who said, think with your head, not your heart. And actually, when you think about it, if you're going to do it off-label, there's so many risks. It may not work. You haven't got the expertise of everybody, and then the truck won't happen. So I've gone from, I want to start my daughter on it straight away, to actually slow down, we're in a hurry. I think slow down, we're in a hurry is the most important thing to think about, because unless we do it in this controlled way, using the expertise, then it won't work. And I'm in a very fortunate position. I'm also a doctor, as a dad as well, so I can see it from both sides. And now I've realised that I've changed my view completely. And when I first met these two people, mine was, I want to get Frankie on it. But actually, I've realised that we need to do it in a controlled way. And in terms of your question, after this, we've got a meeting with a UK team because we're trying to make a UK, which will take European patients, working with the Americans to take the rest of the world. So we will try and get numbers up very, very quickly and try and make it work as quicker as possible. But that was just as a dad to say, I know exactly what you're feeling. I'm exactly the same as you, but my head's kicked in over my heart, who's a devastated dad, as actually, we need to slow down, we're in a hurry.
Thank you so much. I'm gonna really rein it in this time and say thank you so much to Dr. Lambert and Dr. Thompson for coming all the way and presenting to us. I'll also share that they will be with us for the next couple of days, and we'll be able to ask them, I'm sure, a myriad of questions, but we're so glad to have them here and to welcome them to us, and I know they're very interested in meeting and speaking with all of you throughout these next couple of days as well. So I'm just going to wrap up with a couple housekeeping items. Thank you again. Oh, no. Oh, well. I have a thank you slide that I will be posting on our website with many, many people that we have to thank today for this enormous event. Like I said at the beginning, we've never had this many people here before. So it's exciting at how much we've grown, and we're thrilled to bring together the doctors, everyone at St. Louis Children's Hospital who'll be helping us, the Washington University School of Medicine that's here, Dr. Marwan Shinawi, of course, all of the clinic planners. There were many different departments at WashU that were involved here. We have a PCRU team, the IDDRC team, Department of Genetics, the labs, from everyone, and then of course, for our DESSH Foundation clinic planners, I'd like to just say by name, Colleen Tosti, Melissa Sidebottom, Stephanie Salam, Susan Ford, and Emily Smith for their amazing contributions to facilitating the logistics of everything that goes into this. So we're super, super grateful for them. It will be time to collect your children in one moment, and I'd like to all gather in the lobby for a photo, if possible, while we still have our photographer here. So we'll give everyone a few minutes to grab their children, but first, Kim Turner has one last announcement to make, and then I'll meet you all in the lobby.
Hi, guys.
And a big thank you to Kim Turner, our WashU on the field schedule extraordinaire.
I try. All right, everybody, we've made it through. Okay. So a couple of notes for all of the parents that are seeing or getting their child seen. Tomorrow is going to be a long day. There are a lot of you. We are super excited for you guys to all be here. But a couple of notes. One, if you are new this year or you have not been here since 2022, I need to talk to you to get you consented, since this is a research study. It won't take very long. However, if you have an appointment with the neurocog testing people that is at another location, come and see me, and I will make sure you have directions to get there, and I will meet you there later, okay? For everybody who's looking for their schedule, I have it. And it's the correct one that you will be able to use for the rest of the week. However, there are some other little testings here and there that we would like to try to fit in, so I will just talk to you guys as I see you coming in. Most of this is just going to be conversations for parents and things like that. If you guys have any questions, again, my number is on there. If you need anything, please let me know. But again, if you guys want to go grab kiddos, we can take a picture, and then you guys can all leave and get some food. All right? Thank you guys so very, very much.